As we all know that there are many centers coming up in the country for patient care, and proportionately the demand for blood and blood components is going to rise. As madam is saying that it is an terminus, bus terminus, but I use it as a kitchen, you see. Kitchen, you see, the more the members, family members, more you require the demand. So transfusion service is a lifeline. And especially the word today, patient blood management, I was thinking, hearing from the talks, that I think now the time is that from patient blood management, we need to term it as a community blood management or a public blood management, because this is just not restricted to the hospitals. I think this has to involve policymakers, our leaders, ministries of health, departments of health, as well as secretaries of health, because it is through their, we need a strong commitment of the government to take these ideas forward, because this is just not managing in the hospital setting, but to start various prevention programs. Like we have our Anemia Mukt Bharat program, Janani Seva Suraksha program, because all those are concepts to preserve life. Basically, anemia, as we all know, it's a global problem, and this is one of the most common medical problem which is affecting the the mankind, as per WHO estimates. So I think I must congratulate Dr. Geeta and her team for inviting us and organizing this event especially on this key issue, and thank you for making us here. And we from the Indian Society of Transfusion Medicine also, I especially give our sincere gratitude and greetings to all of you for successfully organizing this. Thank you very much.
So, following Guru's footsteps, we have our very own PGI alumnus, Dr. Satyam Arora, who is ISBT's Regional Director for Southeast Asia. He is following the footsteps of his PGI gurus, respected Professor R. Sharma sir and Neela Marwa ma'am. Dr. Satyam, please.
Thank you, ma'am, and good morning, everyone. Respected Director ma'am, Dean ma'am, my senior faculty members and teachers from PGI Chandigarh. It's an honor and privilege for me to join this CME today and on a very pertinent topic of patient blood management. On behalf of the International Society of Blood Transfusion, I extend warm greetings to all faculty, students, clinicians, and policymakers gathered over here. PBM is not just a technical protocol, it is a patient-centric approach to manage patient, especially in our region where the demand is rising and we need to be more focused on treating the patient than only to provide blood unit. I encourage everyone over here to discuss, engage into these discussions and absorb and ask questions and use this platform, which is very well organized by this department, to have more interdisciplinary discussions on this topic of PBM. Thank you, ma'am, for organizing, and your team has done a great job in hospitality, in managing our time at Rishikesh, especially the evenings with the Ganga's bank, and it's an amazing experience. And I think it's a holistic management that your team has been doing. And I really wish this CME a grand success, and I wish all luck. And since yesterday evening that we've been spending time at the banks of Ganga, I thought that where PBM can intersect with the flow of Ganga, and something that I wrote over the evening was, like Ganga, blood is precious. PBM is our commitment to keep it flow pure, purposeful, and preserve it for our future generations. Thank you.
That's wonderful, Dr. Satyam. Thank you so much. So now I would request our Honorable Director, ma'am, to address the gathering and encourage the audience. Ma'am, please.
So thank you, Daljit, for those kind words and conducting this particular session so well. And I was actually looking at the program, but first I must address all the dignitaries who are present here. Our own Dean, Professor Jaya Chaturvedi, Professor R.R. Sharma, the Head of Department of Transfusion Medicine from PGI, Dr. Preeti, Dr. Ravneet, Dr. Meenu, and of course Dr. Geeta, Dr. Ashish, Dr. Satyam, all of the people who are present here, all the guest faculties as well as the students and our own alumni who've come to attend this particular workshop. So when I was looking at the program, so I found things like climbing the mountain, then flowing with the river, then meeting the challenges, strike when the iron is hot. I could imagine, that this is Dr. Geeta Negi behind all these ideas. And of course, Dr. Ashish Jain. You all must be surprised to know. अच्छा दलजीत ने किया ऐसा ना? Okay, so like gets like, they all एक ही थैली के हैं सब लोग. So, as you all know, Dr. Ashish has actually written our anthem, our AIIMS anthem. And you should listen to it sometimes because you are, And they were so quick to write it and execute it, and we were able to play it in our convocation at that time. It's like almost like 1 year old, I think, 1 or 2 years old. And so this department is really very, very forthcoming. And today, because I have to speak not like maybe as a pediatrician or as a CEO of this organization, so I have to see how well and how well coordinated they are in their efforts, and they haven't even got all that which they need for the space wise, I would say, because I used to see when Chandigarh, we had this Rotary Club of Chandigarh. They had a big building for a blood bank, and although not many activities were taking place over there, but it was something which they were really proud of. And even PGI did not have too much space. I mean, as far as space is concerned, it's always been a constraint because blood bank, initially it started with blood banks. And that was like one service which was available. But now we know what is transfusion medicine, how many things it covers. Blood is actually the most important and I think the most flowing and the most voluminous organ of the body. And after skin, I think this must be the second one. So this is something which really needs so much attention and care. And I was really impressed with this team of PBM. It really took me time to complete the abbreviation PBM, then I realized, okay, it is patient blood management. It could be several other things because we have all kind of PBMs these days. But since I belong to this field of evidence-based medicine, so we have been connected with this patient blood management theme, and that is having evidence-based strategies for optimizing blood management. This could be domiciliary, this could be pre-operative, this could be operative, this could be post-operative. This could be related to all the situations where blood is being used. And coming to evidence, we as pediatricians, as newborn people, we came out with a strategy of milking the umbilical cord, which is done by the obstetricians. And that, leads to blood being transferred to babies, and those babies then develop less anemia because during infancy, otherwise they get anemic and they need iron. So many of these strategies are actually evidence-based. People did randomized control trials on these strategies and they found that yes, this is what is done. Then is, there's auto-transfusion. Like you have been saying that, people can donate their own blood. If you're going in for surgery, you donate your own blood 2-3 months before you start off. And then use the same blood if it is required. Similarly, during massive trauma, people lose so much blood and you can use that blood. Maybe you can clean it and use those blood products for the same patient. So many new strategies, new technologies. We know that technology has really changed the world and medicine, and in blood transfusion, I think in transfusion medicine, I would say, it is something which has really made a lot of changes. So I think the road is ahead and there's no stopping. I know that Dr. Geeta and the team will not stop and they will become. become the best. They are already actually regional center for training for various medical colleges, which they are accomplishing. The AIIMS Rishikesh blood bank is very well stocked, and we are on the on the web, and people are making use of the whole of the state, and other states are making use of these blood transfusions. We also tried our drone service for delivery of blood products, and that is something which is always in the offing, and we can help our trauma victims with those kind of services. So many new things, new avenues are there. I'm sure you will keep getting ideas. Dr. Geeta also belongs to the medical humanities stream, because she has been heading that center which we have put together. And I know all these teaching strategies, interactions, they all come about because of all these new thinking, new way of thinking, which is always there in this department. So congratulations for this wonderful CME that you have organized, and thank you very much for associating me with this. Thank you very much. Jai Hind, Jai Bharat.
Thank you so much, ma'am, for your influential message and words of wisdom. You have very talked about evidence-based medicine. We will be talking about it in the subsequent sessions throughout the day. Thank you, ma'am. Thank you, everyone. Now I invite Dr. Ashish Jain to kindly propose vote of thanks.
Yes, ma'am. अभी करते हैं. So, good morning everyone. On behalf of the organizing committee, it's my honor and privilege to deliver the vote of thanks at the inauguration ceremony, ma'am, for your encouragement and unwavering support in promotion, continuous medical education. Your vision enables platform like us this to thrive. We are extremely thankful to ISBT for not only providing financial support but also for collaborating with us and guiding us step by step for our organization of this CME. A heartfelt thank to our renowned speakers and teachers and all resource persons whose expertise in engaging presentations will help to deepen our understanding of patient-centered approach to transfusion. Your contribution will not only update us on the evidence-based practices but also emphasize the importance of shifting our focus from blood products to holistic patient approach. To the organizing team, residents and support staff, thank you for your meticulous planning, coordination and hard work. Although our organizing chairperson, Professor Geeta Negi ma'am, and organizing secretary, Dr. Daljit ma'am are the main organizer, but I could not resist to mention their hard work and passion. Geeta ma'am, of course, is well known for organizing events in her unique way, and Daljit ma'am is known for her stylish way. So we all are witness here for their combo of unique and stylish presentation. We all seen this is, so these are just one kind of example. Even all the planning and decoration, even that all those ideas were thoroughly discussed, and how they are executed, only our team can understand this. So very thankful to you, both you ma'am. A special thank to technical staff, audiovisual team, photographers, housekeeping staff, security staff and other staff for their support, and our caterers, designers and all the companies who have installed stalls. And last but not the least, a big thank to all the delegates who were motivated from the beginning of registration and also keep on motivating us. So whenever we are some dip in our motivation, we see the number of registration is increasing. हम कहते थे कि 2 बढ़ गए, 3 बढ़ गए. So suddenly there is a spike in the motivation of organization of event. And lastly जब हमने देखा कि registration number is huge, so that अब तो मजा आ जाएगा भाई, बहुत अच्छी सी हमें करना है. So the morning we have seen the enthusiastic mini oral presentation of the participants, and the presidents has come with with their posters. It looks like there's some educational events is happening, and everybody is saying, even guards understand कि आज कुछ बड़ा होने वाला है. So it's about the delegates and the residents who are the main thriving force for this event. Your active engagement and enthusiasm will reflect the growing commitment to evidence-based and patient-centric transfusion practices. We hope this CME will not only broaden knowledge but also spark new ideas and practice in clinical work. Thank you all the persons for this inauguration and for the CME. And in the evening, I think a lot of collaboration with your knowledge and our knowledge we will share, and we will learn a lot about this patient blood management. Thanking you.
थैंक यू डॉक्टर आशीष. आपने इंग्लिश में बहुत ही बेहतरीन धन्यवाद किया सबका, बट दिल में अभी भी कसक बाकी है आपकी कविता की. तो इसीलिए वी आर गोइंग टू प्ले आवर इंस्टीट्यूट्स एंथम, सो which was planned, very well planned by Dr. Ashish and Director ma'am. Now I request everyone to kindly rise for national anthem.
पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you all. So before we break for tea, I request everyone to join us in the amphitheater, our newly built amphitheater, for a group picture. It's solarium. Outside the auditorium. So after this photo shoot, we'll have a coffee break, and that's at the dining area at level 2. We'll resume for next session in half an hour.
हाँ हाँ प्लीज़ सी प्लीज़ मैंने लोड करवा दिए थे. सेशन Yeah, ये तो CV है.
No, this is the CV. Just a minute.
Yeah, sure.
रिकॉर्डिंग सही चल रहा है, बिल्कुल सही. ठीक है, बढ़िया है. एक बार प्रियंका को कॉल करो ना, पूछो कि वो कहाँ पे रखा हुआ है. क्या PPTs कहाँ पे है. यही तो है. प्रियंका कहाँ है. ये
तो पीछे तो नहीं रोक दिया, यही से चल रहा है. ओके.
जो ऑनलाइन वो सर्च करना था आपको.
हाँ.
वो इसी में करने हैं ना.
प्रियंका, ये PPTs कहाँ रखे हुए हैं. मैम को एक बार दिखा.
जो आप बोल रहे थे ना, इसी पे करना है ना आपको. मैं इस पर नेट कनेक्ट कर देता हूँ, फिर रोम में आपको लिंक डाल देना उनका. ठीक है. उसमें पेन ड्राइव पे रखा हुआ है.
ओके. लोड कर दो.
ये है ना PPT मास्टर.
बस ये है. इसको कॉपी करना है. इस पे हम प्रेजेंटेशन मोड में आ जाएगा. अच्छा, इसको यू वांट टू पेस्ट इट हियर. आई विल जस्ट वांट कॉपी इट.
Let it be like this, no?
ठीक है, आई एम ओके. ऐसा ना बंद हो जाएगा.
नहीं.
आई विल जस्ट डू इट. प्रेजेंट भी चलता है. हाँ मैम, प्रेजेंट भी चलता है. इसमें सर पहले फोटो के लिए चल लो. एक सेकंड. वो फनी वाला सीवी तो नहीं है ना. नहीं पक्का. हाँ, मैंने चेंज कर दिया. मैंने सारे चेंज कर दिए.
वो आके कर देते.
इसका अडाप्टर तो लगा लो.
ये हाँ वहीं पे.
जल्दी खींचना.
जो डीपी है तेरी वो भी ऐसी बना देती है.
नहीं वो तो मैंने वहाँ हिंदी दिवस पे दिया था ना लेक्चर. रुक जाओ. नवनीत जी थोड़ा साइड हो जाओ. नहीं आ रहे. वेरी गुड. बस चलो.
पीपीटी है, उनका ही पीपीटी नहीं है हमारे पास। यशवंत सर है। निकाल दिया तीनों का। कॉपी क्यों नहीं आ रहा है? कहाँ के नहीं दे ये यशवंत सर को कहाँ पर है?
इमरजेंसी में भी जाओ, इमरजेंसी में जाओ, ठीक है। मेरे को अपना प्रेजेंटेशन इसमें डालना है। हाँ, प्रेजेंटेशन में डाल देता। हाँ, मैं पेन ड्राइव है। कॉपी कहाँ से हुई?
हाँ, यहाँ से सर
कॉपी
डेस्कटॉप पे सर।
पेस्ट ये गया। खोल के देख लीजिए। ठीक है। ये इजेक्ट कहाँ से होगा?
सर आपको आपका पीपीटी।
हाँ, बस हो गया मेरा।
हाँ सर, मैंने इजेक्ट किया सर।
ये है।
सर रिमोट का सेटिंग्स
निकाल लो।
हाँ सर निकाल।
1 मिनट अब देख लो ना उसे
मैं
फिर से।
वापस एक बार जाए इसमें।
क्योंकि कभी कभी क्या होता है, ये निकलने के बाद ये खुलता नहीं फिर। ठीक है, थैंक यू, थैंक यू।
इसका मैंने तो बता तो ये वाला हमारा मेन पीपीटी तो खुला हुआ ही है।
मैम तो आई नहीं है।
नहीं, मैम तो चले गए तो अब उनका तो कुछ नहीं करेंगे।
तो फिर मेरे इसमें चेयरपर्सन कौन रहेगा? जया मैम रुकेंगे अभी?
नहीं, सिर्फ श्रीपर्णा मैम रहेंगे।
तो श्रीपर्णा मैम तो आई नहीं अभी।
मैम
हाँ।
तो है, शायद आ जाएंगे फिर।
वो तो आई नहीं है। संजय सर आए हैं बस। और हाँ, बस संजय सर ही आ रखे हैं। जया मैम शायद चली जाएंगी।
हाँ, मैम तो चले जाएंगे। मैम नहीं होंगे तो मैम ने वैसे भी बोला था कि 2 ही होंगे वैसे चेयरपर्सन में। तो
मेरे ख्याल से मैम को तो नहीं देखा मैंने अभी तक। श्रीपर्णा मैम को
फुली दिखते हैं, आ जाए पता चला इसमें तब तक। लतिका मैम का पापा का नाम
सत्यम सर का है।
हाँ, सत्यम सर का है मेरे पास। इसमें से डालना है बस इसमें। इनका हो गया नेट चला के।
पीपीटी लॉग भी नहीं किया। हेलो हेलो, नेटवर्क नहीं आता। दोनों सेशन साथ में ही होंगे ना यार? कि हाँ ये दोनों। हेलो 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 हेलो, यार मैं पीपीटी सेट कर रही हूँ, आती हूँ।
अरे आजा आजा, मैं वेट कर रही हूँ तेरा।
हाँ हाँ आइए। लॉग आउट हो। जल्दी आ जाओ, क्योंकि इस सेशन का भी सिर्फ दाऊद सर का बचा, बाकी सबका तो आ गया है। वही तो यहाँ तो 3 ही होंगे ना। इनकी पीपीटी में तो कुछ डालना नहीं है, बस इनके सारे सबके है। जया मैम का नहीं होगा, बस इनका पूछ लेंगे सुपर्णा मैम का है कि नहीं। इन्होंने कुर्सियाँ अभी से क्यों रख दी? कुर्सियाँ तो सेकंड वाले उसमें आएंगी, जो वो बीच में नहीं करेंगे इसलिए। बनी कुर्सियाँ बीच में व्यू तो आ रहा होगा या फिर नहीं आ रहा होगा, पता नहीं, दिखता है। हेलो ये कौन है? यशवंत सर है ना, जो मैम ने भेजा मुझे वो। हाँ सत्यम अरोड़ा। से होगी कौन सी इनकी, इनका टॉपिक क्या है, टॉपिक भी तो हमें नहीं पता। सर का दाऊद सर ने पूरा पेन ड्राइव दे दिया, अब पता नहीं ये कौन सा होगा। ये होना चाहिए एनीमिया एंड करंट रिकमेंडेशन पेशेंट ब्लड मैनेजमेंट। हमारी वाली का भी ये बस लगा के रखना है, हमारी सारी इसमें ही रखी है। चल रही है आशीष की चल रही है। इसमें 4 ही ना, आशीष दाऊद सर वैद्य मैम अश्वती जी आरती 1 2 3 4 5 6 ही है ना। इसकी नहीं चल रही यार, इसकी कुछ गंदी आरती की। इन्होंने मना नहीं कर दिया था? नहीं है तो अभी मना, किसी ने मना किया था ना कि मैं प्रेजेंट नहीं कर रही पोस्टर, ऐसा कुछ बोला था। पोस्टर तो चलो ठीक है, ये किसी को मैसेज मैम ने ग्रुप पे भी डाला था ना। ये कौन बैठे हैं यहाँ पर, ऐसे ही बैठे हुए बुक्स वाला कोई स्टाफ होगा शायद। अभी का तो हो गया वाला, चलो कुछ खा के आते तब तक। स्लीप कहाँ से होता है इसमें? hope you all had a pleasant and refreshing coffee break. It's now time to We now begin with our second session, which is an interactive session on patient blood management in perioperative surgical, obstetrical, and pediatric settings. This session will explore the applications of PBM across diverse clinical scenarios, making it a vital component of today's discussions. To chair this important session, I have the honor of inviting the esteemed chairpersons, Dr. Shriparna Basu ma'am, Professor and Head Neonatology, AIIMS Rishikesh, and Dr. Sanjay Agarwal sir, Professor and Head Anesthesiology, Rishikesh. Welcome sir, welcome ma'am. I now request the chairpersons to kindly take to proceed with introducing the speakers of today's session. Dr. Shriparna Basu ma'am, she is MD Pediatrics, MSc Neonatology from Southampton, UK, FRCPI, FRCPCH, Professor and Chair, Departmentology, AIIMS Rishikesh. Her achievements include Fellow of Royal College of Pediatrics and Child Health, London, UK, Commonwealth Scholar, Postgraduate Certificate, Medical Education, Dundee, UK, Clinical Observer of American Academy of Pediatrics, USA, David Baum Prize of RCPCH, UK, teaching and research experience over 25 years, and publications include Index Journal over 200 and President NNF UK State Chapter 2023. Dr. Sanjay Agarwal sir, who is Professor and Head Department of Anesthesiology, AIIMS Rishikesh. Clinical interest includes neuroanesthesia and airway management, and achievements include 22 years of teaching experience, 17 in various national and international journals, ACLS and ATLS instructor. I would request the chairpersons to kindly introduce our speakers. No, ma'am.
Our first speaker is Dr. Yashwant Singh Payal. He is MD Anesthesia, Fellow Pediatric Anesthesia. He is a professor in the Department of Anesthesiology, AIIMS Rishikesh. He had 55 national and international publications, and his area of interest include pediatric, neonatal anesthesia, and critical care. So the stage is yours, Dr. Payal.
West.
Thank you. Thank you, ma'am, for your kind introduction. So, to start with this today's CME, that is patient blood management. We all sitting here for the patient-centered approach for treating the patient and managing the patient. And our journey definitely will start right from the point of entrance into this topic is anemia and pre-operative anemia. Later on we'll go with some sort of intraoperative blood conservation. The journey will end after treating this anemia. No doubt, maybe this anemia in a chronic origin or be a acute origin. So let us start with our topic, the preoperative anemia and intraoperative blood conservations. Before I start my journey, the preoperative anemia, in these slides nothing new, we are all aware of the fact what is anemia and how to treat it and what is the basic strategy to manage these patients. WHO that has already make a threshold for the defining as this anemia. They have already make the threshold for adult male. It is the value less than 13 gram per deciliter, and this value is a little bit less in female patient. Normal healthy female patient, it is 12 gram per deciliter. However, in pediatric this obstetric patient, it has been defined somewhere like right from less than 10.5 gram per deciliter to 11 gram per deciliter, depending on the status of pregnancy, that is the first trimester, second trimester, or the third trimester. In first trimester it is 11, and in second trimester it is 10.5, and in the third trimester it is gram per deciliter. To considering these threshold values from the WHO guidelines, the prevalence rate of this surgical, I am talking about the surgical patient, the prevalence is around 30 to 40%. This anemia, whenever we are dealing this patient in a surgical way, they are always associated with some increased risk, like increased morbidity and mortality, longer hospital stay, and associated with the higher transfusion rates and the complication associated with the blood transfusion. Now going back to our causes of anemia, there are a long list of causes of anemia. I myself is concerning only broad categories, that is the nutritional one, that is iron deficiency, that is the most common cause, or the micronutrient deficiency. Second broad category is the blood loss, and third is the coagulopathies. Now there are so many classification and of these anemia. I am not going into the detail that we all know. Iron deficiency anemia may sometimes be iron deficiency occurs without anemia, with anemia, and there are a lot of things that can be put into these broad categories. So, and another thing, that is the blood loss that ultimately leading to the anemia, that may be a chronic blood loss, acute blood loss, surgical blood loss, and other causes as well. Third thing, this is the broad category, one more broad category that we are more concerned, that is coagulopathy, that can be acquired congenital and iatrogenic. These are the things that can become under the broad category coagulopathies. So when we are considering the anemia, preoperative diagnosis is mandatory. Diagnosis also is a broad list of batteries that can be used to detect the anemia, to diagnose the anemia nature. I am just concerned about the surgical way of diagnosing this. For we need a CBC, serum ferritin, and transferrin saturation, sometimes CRP, if the inflammation is suspected. This anemia, I think it is better, and it's a good practice, evidence-based practice. It is better to correct this anemia before you take your patient into the operation theater, and the treatment also depend upon the time availability for this in your hand. So it is better if you are considering these patients in a perioperative evaluation, at least more than 4 weeks is required for their conservative management. Primary thing to manage these patients' anemia is getting into a causating way of treating these patients. Find the cause and treat the cause, that is the dictum. Otherwise, the patient most common cause, that is iron deficiency anemia, that lead to anemia, iron supplementation, erythropoiesis stimulating agent can be given, or a folate of vitamin B12, and if required, rotational thromboelastometry. Definitely, it will help in preserving the blood or controlled hypotension. That can be another strategy used by the anesthesiologist to conserve the blood intraoperatively. And intraoperatively, the temperature is one factor that can lead to excessive blood. If you are controlling your patient and a temperature is maintained, then intraoperative loss can be prevented. Pharmacological measures to conserve the blood intraoperatively can be used while the patient is operated by the surgeons. They can use these fibrin sealants and the topical hemostatic agent like Surgicel. They are colloid based or gelatin based, and they usually help in maintaining the mass so that platelet and coagulation cascade can help into the making of plug and hemostasis. Surgicel and gel form, these are and there are so many other ways of doing this, come into this very broad category, that is fibrin sealant. Other agent, the pharmacological agent like antifibrinolytic agent, that tranexamic acid. There are evidence-based practice, and there are different level of evidence for these using these fibrinolytic agent. They are having a result that whenever we are using these fibrinolytic agent, loss is less as compared to when we are not using these agent. They are tranexamic acid, aminocaproic acid and aprotenin. They are being used pre-operative and then continue it to the intraoperative period. Now coming to the autologous blood technique, that is what Dr. Geeta was telling me. Earlier we used to give the patient giving the patient own blood to him. That can be done in 2-3 ways. First is the preoperative autologous donation, when patient is giving his own blood to the bank and it is being kept there and it can be used later on when it is required, but in a certain period of time it must be used by the patient himself. And second method is the intraoperative cell salvage, and third one is the acute normovolemic hemodilution. Now first one, the preoperative autologous blood technique. That preoperative autologous donation, that is PAD, is involved when a patient is donating their own blood before surgery for the potential transfusion during and after the procedure. So that may be used in such kind of patient where they don't want any other blood. There is one group of patients, that GR witness group of patients, they don't allow any blood product to be used in their body. So, and another thing, there are so many other indications for using the preoperative autologous donation. Indication is different that I have not discussed here, but definitely that one method, that preoperative autologous donation, can be used to preserve or to conserve the blood intraoperative. Blood is a very important organ that Madam has already discussed after skin. And the aim of this preoperative autologous donation is to minimize the exposure to allogenic donor blood and its associated risk, and beneficial for the patient, those who are undergoing surgery with anticipated high blood loss, like in orthopedic surgeries or the vascular or the cardiosurgical procedure. Second is the intraoperative cell salvage. In this cell salvage, the intraoperative cell salvage is the method that harvests the red cell which is shed during surgery and the procedure and preparing them for safe return to the patient's own circulation as the autologous blood transfusion during immediate after surgery. This is the flow diagram, schematic diagram of how the blood is being taken. The blood which is being shed from the patient is being collected into a bag, and that bag is being goes to the, after mixing it with the heparinized saline, and it goes to the cell salvage machine where it is segregated, centrifuged and washed thoroughly and returned back to the patient. That is how we can conserve the blood. That is a one method which is very important for the blood conservation. And third one is the acute normovolemic hemodilution, and the amount of blood that is withdrawn in varies right from 3 unit 450 ml to 500 ml each. We can take the blood from the patient pre-operatively and This has been retransfused to the this is in a perioperative period. We take the blood from the patient and we'll keep it there only. And once then same amount is being replaced with the saline or the colloid or crystalloid, whatever solution it is based on choice of anesthesiologist, and it can be discussed with the surgeon as well. So that amount, the blood which is we are using that time of surgical procedure is a little bit of diluted blood, and patient will. There are certain criteria for putting the patient on acute normal ANH. Patient must have fulfilled these criteria, and after that we can go with this ANH. And later on, when the reverse order, the blood is being taken out from the patient, 1 unit, 2 unit, can be retransfused after when the surgery is completed and hemostasis is being achieved. How to calculate this blood amount, how much to take out from the patient, that is totally volume based, formula based. That is volume what we are taking from the patient is being calculated by the formula that is already been said there. Estimated blood volume, E, and where the BV is the blood volume, and rest of the things they are already mentioned in the initial hemocreatine plus final hemoglobin. That can be achieved. So this is the way how we can calculate how much blood is being withdrawn from the patient and later on will be transfused back to the patient. So there are some references from where I had to prepare these slides. Basically there are so many references. One of them is the WHO guideline for referencing the blood transfusion and the PBM, and other references that are there. So this is all about the basics of this one. Thank you.
Thank you. Thank you very much, Dr. Payal, for such an informative lecture. I think since there is a brainstorming session, so all questions can be dealt in that way. Thank you.
This is basically very basic to start with our journey. I have not gone into.
Brainstorming later.
Thank you, ma'am.
This is the basic.
Thank you.
So I will now invite our second speaker, Dr. Latika Chalva, who is the additional professor in the Department of Obstetrics and Gynecology. And the topic she will be talking about is PBM through an obstetrician eye. A very important topic because there seems to be always a conflict between obstetrician and a blood bank for blood and blood products in the perioperative period. So she will be taking her own points, her own views from the obstetrician. Dr. Latika.
So the Taj Mahal stands today as a grand tombstone to a queen who died of postpartum hemorrhage. And while centuries have passed, we still have not been able to stanch this tide. PPH is still responsible for nearly 70% of the maternal deaths in our country. A very good afternoon, respected chairpersons, ladies and gentlemen. I will be talking about patient blood management through an obstetrician's eye. I had a morning discussion about what PBM is, so I'm not dwelling on that. However, one point I would like to begin my presentation with is that PBM is not only about transfusions, it's about avoiding unnecessary transfusions. So the key principles as an obstetrician that I have understood for patient blood management are that we need to optimize the red cell mass of our patients antenatally. We need to minimize the blood loss during surgery, and then the postpartum care which is required for these women. So if you look at the data that has been given by the government of India, more than half of the pregnant women in India are anemic. But if you want to take a stroll through our labor room in the evening and you pick up the patient's files, you might find that this number is slightly lower. And anywhere between 70 to 80% of the patients who are admitted at any given point of time in the labor room are anemic by the standards that have been explained. And as the first and the foremost component of PBM, optimization of red cell mass will include detection and early treatment of anemia during the antenatal period. And interestingly, our patients will give us 8 to 9 months for this. So the government has been doing its bit with the various national health programs, the most prominent one being the Anemia Book Bharat. And then at the clinical level, we try and counsel our patients, our pregnant patients, about iron-rich diet, try to cook in iron utensils when you're pregnant, And this should be done each time when they are visiting us in the antenatal OPDs. And not just prescribing them the 100 tablets of oral iron, but also ensuring that they are actually consuming those tablets, and if they're taking it, they are able to tolerate it. Because if they can't tolerate it, they'll just dispose them, and then once they come to you the next time, they're too scared to say, no, I'm not taking those tablets. So, while IV iron has its set of indications, and if I probably show this slide to one of my, very, very senior faculty, I'd probably be scolded for this. But in the context of the poor and nutritionally deficient pregnant women in our country, we must maintain a lower threshold for its use. Relying solely on diet and oral supplements is often too optimistic. IV iron, especially FCM, and if not FCM, maybe sucrose, offers definitive correction when it's needed the most. Cost, however, may pose a challenge sometimes, so maybe we'll be having a discussion later on during the day for this. So the second component of PBM in obstetrics is managing blood loss during surgery and delivery. So the protocols of management of obstetric hemorrhage are constantly evolving. And the latest revolution in the management of obstetrics has been the E-motive bundle, which is now being endorsed by all bodies, including the WHO. And if we all remember our MBBS days when we read Datta, and it said that 500 ml of blood loss is absolutely okay in a patient of vaginal delivery, and 1000 ml of blood loss, okay, that's not a problem in a cesarean section. But long are those days, we need to unlearn that concept. And according to this E-motive bundle, even a 300 ml of blood loss is significant enough. We must consider it sinister. And then the moment we realize that this blood loss has happened, we need to trigger our bundle. And all these approaches have to be done simultaneously for the prevention and simultaneous treatment of a patient of PPH. And that includes early detection. You start the bimanual massage of the uterus, give the oxytocin, give misoprostol simultaneously, and never forget tranexamic acid, because it's been found to be life-saving in a patient of massive hemorrhage if a single dose is given within 3 hours. Then IV fluids have to be given. 1 liter can be given safely, crystalloids. Beyond that, if you require some amount of blood, if you still require fluid, it should be replaced with blood or blood products. And E is early examine your patient. If you find some abnormalities, you escalate, you call for help, and call for help in a patient of PPH should not be taken as that you have lost. So in obstetrics, we say, in fact, the first thing should have been you call for help, or shout for help for that matter. You call your senior if you think that the patient is having PPH. And then, yes, patients today for us is patients of placenta agrita spectrum. So we plan our intraoperative steps well in advance. We map the placenta. We try and give our incision behind the uterus to deliver the baby. Seniors are usually operating in this case. We take the help of intervention radiologists to embolize the internal iliac or to embolize the uterines to prevent bleeding. But these patients have the potential to bleed massively. And this sort of a bloody scene where there is blood everywhere in the OT is oft encountered. So the residents will be running to and fro from the blood bank, carrying bags of PRBCs and FFPs. And so it's usually the little ones, the first years, the ones who have just joined. So then they ask us what to bring, kya lana hai. So using the ATLS principles, we're trying to change the management in our department as well. So if the patient is requiring more than 1 liter of fluid, which can be safely given in a patient of massive hemorrhage, beyond a liter of crystalloid is best. So we tell them blood needs to be replaced by blood. And then they'll ask us, kaun sa wala lana hai and kitna wala lana hai. So what blood products, how much blood products is to be given. So we've made an ABG machine available in the maternity OT for the benefit of the anesthesia residents and also for our own residents. And we're trying to change the concepts, trying to help them understand the physiology. So it's a beautiful test, can be done very quickly. It gives you a serial monitoring of the fallen hemoglobin levels during the course of the surgery, doing it serially. If the patient continues to bleed, you'll get an assessment of the hemoglobin, you can get an assessment of the lactate levels, and a beautiful parameter-based deficit, which tells you whether this patient is going to require blood or not. So if the base excess is 0 to -2, she doesn't really require blood. -2 to -6, she may or may not require blood. Maybe it's just your fluid that can help her. And if it's from -6 to -10, definitely this patient is going to require blood. You ask your blood bank to issue your 2 or 4 PRBCs according to the clinical condition and the parameters. And if this parameter has reached to -10, you intimate your blood bank to kindly activate the massive transfusion protocol. And a thromboelastography, this provides a real-time assessment of blood coagulation dynamics. and it can guide us as to which product is actually required for the particular patient. So I think we're in the process of acquiring this for our institute, and if we get that, the PBM will be even at a better level. So it will actually tell us that, okay, now this patient requires FFP, or she requires platelets, or you have to give a fibrinogen. So that can be a part of PBM in these patients who are having severe or massive hemorrhage. So we are using the ABGs, we're trying to get the TEG, but in a patient, when you're actually in the OT and bleeding massively, so by massive hemorrhage, I mean 2 to 2.5 liters has already been lost. So in that condition, our protocol is to that of hemostatic resuscitation. We ask for blood and blood products in the ratio of 1:1:1. That is, 1 PRBC should be accompanied by 1 FFP and 1 RDP to prevent coagulation disorder. And otherwise, if it's a non-massive hemorrhage, if the PT-INR is deranged or if the APDD is more than 1.5 times, we can give FFPs in the dose of 15 to 20 ml per kg body weight. This is done in tandem discussion with the anesthetist, who's also taking care of the patient simultaneously. If the platelet count has come down to 75,000, we consider RDP transfusion to 5 to 10 ml per kg body weight. And if the fibrinogen level is less than 2, we can consider giving cryo, or fibrinogen concentrates can be given. The other thing that we do is, if we have transfused 4 PRBC, 4 FFP and 4 RDPs, the next patient is still requiring resuscitation and she is still bleeding, then we can ask the blood bank directly for cryoprecipitates the next time. So this was about the intraoperative points to take care of. And then the postpartum things that we need to be certain before we discharge our patient, that in the current scenario, we are trying to raise our threshold for transfusing PRBC in the postpartum. So if the patient is stable, hemodynamically she's stable, she is asymptomatic, not having symptoms of anemia, then the cutoff for transfusion, even for us nowadays, is 7 gram percent. But definitely clinical judgment is required, because supposing this patient has bled from 12 gram and now she's come to 6.5 or 7, you may consider her giving a PRBC and then building her up with oral iron or IV iron before you discharge her. But if the patient is supposing 8 gram and she's giving you symptoms of anemia, she's tired, she says, I'm feeling dizzy, even going to the toilet, I'm feeling dizzy, then you may transfuse. And our obstetric management is not complete without optimization of anemia, and most importantly, our iron stores, because if she came to you anemic and you send her off with depleted iron stores, this is not a good clinician. So administration of IV iron to cover an individually calculated iron deficiency in the postpartum women should be a ritual, as we are trying to do that in our labor room. And again, the cost is a challenge. If the patient cannot afford FCM, try and convince her to take the multiple doses of iron sucrose that are there. Interesting, I mean, it's good for us because in our labor room, the AIIMS scheme sometimes covers the FCM. So if during that particular time period the FCM is available, we ensure that our patients are getting FCM before they're going home. So the take-home messages are, PBM is not about avoiding transfusion, it's about avoiding unnecessary transfusion. You optimize the red cell mass antenatally, control the blood loss proactively, use blood wisely, and before discharging, correct anemia, send her home strong, not just surviving. Thank you. Thank you.
Thank you, Dr. Latika, for very nicely covering the topic, which is very important from obstetrics.
So I invite our next speaker, Dr. Satyam Arora. Dr. Satyam is additional professor in the Department of Transfusion Medicine in PGICH. Under his belt, he is a regional director, Southeast Asia for International Society of Blood Transfusion. He is the chair of Pediatric Transfusion Subgroup of ISBT. He is a certified advanced biotherapy professional by AABB, and he is a member of Technical Resource Group of NBDC and DGHS. He is a member of the panel of experts for the National Donor Vigilance Program of India, and he is also a member of Special Interest Group on Blood Donors Management by ISTN. He has been awarded with Director's Medal for Best Teacher Award by PGICH in 2025. He has received Narendra A. Spagaria Award by ISBPI in 2022. He has also received Young Scientist Award by ISTN in 2012. He has over 60 publications and total citations of 1765 with an aging base of 13. And Dr. Satyam will be talking on a very interesting topic, kick into a high gear, contemplating PBM in neonatal and pediatric patients. Dr. Satyam.
Thank you, ma'am. Thank you for kind words, and thank you, the Department of Transfusion Medicine at AIIMS Rishikesh, for planning and executing this wonderful CME. And they've given me a topic of kicking into high gear, and I think it's advisable as we were driving towards Uttarakhand that don't drive too fast. So I'll pace up my speed gradually, and I think by end of my slides we all will be in high gear to understand PBM in pediatrics. So pediatric transfusion as a whole, if we understand, it's from fetus to a young adult to an adolescent. So one size doesn't fit all, and this is something that I would like to highlight whenever we are talking about transfusion in pediatrics. So this is something that we've been, discussing since morning, that it's an multidisciplinary approach to manage anemia and to manage blood health in a patient. And there are three main pillars. One is managing the pre-operative, then operative and post-operative. But what happens in pediatrics and in non-surgical settings, and something that I would like to highlight. So this is how I have outlined my presentation. I will be discussing some unique issues with this patient group. Then something, what are we targeting? Where is the blood going? Do we have that data with us in India? So we'll be briefly touching the incidence of transfusion in pediatrics. Then you're doing a comparative analysis between risk versus benefit. Then some PBM specific, pediatric specific, and just very briefly on pre-operative issues with PBM. So whenever you are transfused, there are many things that goes into a clinician's mind, that there's a unique physiology, there are different threshold and policies that people are following. There are various pediatric subspecialties now. You have a pediatric hemonc, you have pediatric gastro, you have trauma and massive transfusion in pediatrics, then you have neonatology, and everybody requires something very different, which is not uniform. And is there one cutoff? And I saw few of my previous speakers were talking about a magic number of 7, but we'll just see whether that 7 can be applicable in this special population. So we know this population is, they're continuously developing, they're going under a rapid neurodevelopment, they're very heterogeneous, and they have the longest post-transfusion lifespan. So transfusing somebody at 40 or transfusing somebody at 45 or 65 versus transfusing somebody at day 1 of life has a different long-term consequence. And that is something we need to understand when we are transfusing a pediatric child. There are many issues when we go deep into these patients, like physiology, blood volume, do you need to warm blood, what is with CMV screening, compatibility issues, donor sparing and limiting strategies, and irradiated blood. And we've been trying to study this as well as nationally, that what is the variation of practice, where is the place where we can offer some uniformity and some guidelines. So when you see physiology, so there is a concept of when the child is born, there is a drop of hemoglobin. That drop can be significant in a preterm newborn, and that can be one of the reasons why they receive blood. Even clotting factors are not actually working in a level that they should in an adult, and even the platelets can be non-functional or less functional in a low birth weight child, and the immune system is under development. So these are the factors which can interplay when we are transfusing a child. When you see blood volume, is 85 ml per kg, whereas a preterm is 100 ml per kg. So providing them aliquots, providing the volume that they need to be transfused can be very different. And even the iatrogenic blood loss, that can be very significant. Your sampling, your multiple samplings that go to various labs, that can in fact can be one of the reasons why they need blood. Now coming to warming, so do you actually need to warm blood? This is something that gets regularly discussed with our pediatric counterparts whenever there is a new resident. So hypothermia is a significant risk in neonatal age. It can increase metabolic rate, it can induce in hypoglycemia and apneic spells and metabolic acidosis. However, in a routine top-up transfusion, you don't need to warm blood. However, if there is a massive transfusion, you may consider using an inline warmers which are authorized to provide warm blood. Now, coming to CMV screening, whenever we look for guidelines. There's a very famous British hematology guideline, and all these international guidelines, they talk about CMV screening. And whenever we have a new neonatologist in our NICU, they will always come up to and ask, are we screening this blood for CMV? Do we need to screen for CMV? So this is an ongoing discussion. However, this is important to understand that CMV is not something which is significant for us in our population, as most of our donors are CMV positive. So a transfusion transmitted CMV infection is of significance in a preterm newborn, as it is, it can cause many issues with the newborn, and even as small as 50 ml of a CMV positive blood can induce a CMV positivity in a newborn. It can present with fever, respiratory distress, hepatosplenomegaly, even viremia up to within 2 months of transfusion. But we don't do it because most of our donors are positive, even our patients, our mothers are positive, the staff which is there in NICU is positive. So the patient ends up receiving this virus from the community. Even leukoreduction has shown to reduce the incidence and transmission of this virus. Pathogen inactivation is something new, but however, it is not yet established. Compatibility testing. Whenever a newborn sample comes, we request the clinicians to send a mother's sample. Why do we need a mother's sample? Since a newborn doesn't develop any antibodies till the age of 4 months. And to do a compatibility testing, we need a newborn sample. We need the mother's sample. And in case there is a mismatch between the blood group of the mother and the child, then there is a compatible red cell that needs to be given to the newborn. Now, coming to donor sparing strategies and limiting strategies, I think this has grown into PBM. So there was a continuous discussion of reduction of donor exposure in neonatal transfusion, and the risk of TTI, aluminization, immunomodulation, optimal use of resources, and lesser wastage. How do we do? So there is a concept of delayed cord clamping that can offer more blood from the placenta to the newborn. There is a concept of providing aliquots, use of erythropoietin, autologous donation, in even some directed donation. However, there is a risk of TTI along with that. Then there is a dedicated donor program where you dedicate one whole blood to one newborn, trying to give all components. And then there is some intraoperative hemodilution which was discussed by the anesthesia team before me. So these strategies can also be used to reduce donor exposure as well as transfusion requirement. Talking about irradiation, this is needed when you have a newborn who's prone to develop, is immunocompromised, and you need to reduce the activity of WBCs that you're giving through your blood. It is clearly indicated when you're giving an intrauterine transfusion in a case of premature infants, congenital immunodeficiency, and in an exchange transfusion. However, in a young child with congenital immunodeficiency, recipient of a familial blood or a recipient of an HLA matched unit, these are the indication. However, there are newer indication of potential indication with using it even in a term blood. Moving gears, going to something which is routine, which gets discussed with our pediatrician, is whether you can use an old blood versus stored blood. So now we can store blood up to 42 days of life. And this unit in blood bank, we follow a concept of FIFO, where we want to use first in, first out. The older unit gets issued first. However, there have been many studies that have shown that there is no significant harm in using a stored blood. But still, there is a catch when you go deep into these studies. Even the stored blood was of an age of 14 to 18 days. So even in these studies, they were not using blood which was very old. So there is a continuous debate of going into lower threshold or restrictive threshold of transfusion, and this is something that I tried to compile. For all the major studies and guidelines that were published since 1984, when there's a concept of restrictive use of blood had started. And if you see from 1980s to 90s, the cutoffs were lower, and they were only hemoglobin. However, when you come to Iowa trial in 2006, and then there's a Pine trial in 2006, apart from the hemoglobin, they wanted to see the whole cardiopulmonary status of the child, the oxygen support, or what is the need of oxygen and the respiratory support apart from the hemoglobin. So now it's not only one number or a hemoglobin value that can influence the need of transfusion, it's the holistic status of this child. And this is the most recent guideline which is there by the British Society of Hematology. And if you see, it is not only the hemoglobin value, it's the age of the child as well. What is the pulmonary status, whether ventilated or oxygen or even off oxygen. You can go more lower if there is a lesser pulmonary support that the patient is receiving. Now this is something comparison of different countries' guidelines, British versus American versus Australian versus Canadian, and if you see, there is still no consensus. Every country, every institute, although they are very close to the values that they're using, but still there is no consensus. Now coming to second phase of my presentation, that is, incidence, that how much blood is in pediatric population and where are we using it in pediatric population. So if you see, it is one of the most common procedure in an institute in US, and PBM introduction has significantly the requirement of blood, and there is, apart from the overall reduction of blood requirement in the United States, the use of blood in pediatrics is constant and at some places even increasing. So if you see, this is the trend from 1993 to 2014, there is a gradual rise of need of blood and then there is a significant drop. Now this significant drop is because of introduction of PBM, and that is where the success story of PBM is. And it's there with plasma. However, for platelet, the need has been plateaued. But if you see different age group, now if you see pediatric, the need it's from 2.3 to 2.4. It's actually constant. So, even with the success of use of PBM in Western countries, implementation of PBM in pediatric age group, even in Western countries, has been a challenge. Now, what is happening in India? So, there is no exact data of pediatric transfusion in India. Dr. Joy had done a very extensive work in need of blood in one of his studies, which used a Delphi method of analysis, and they showed that roughly around 8% of blood that gets required for the pediatric use. So this was actually an hypothesis for us to start a multi-centric work, and this got started 3-4 years back, where we were able to enroll 23 medical institutes across country who received nearly 4 lakh blood requests. Out of them, 52,000 were pediatric blood requests, and I'm happy to share that AIIMS Rishikesh was part of this study along with PGI Chandigarh and Sector 32 Government Medical College in Chandigarh. And we found that overall need of blood is around 65% is for medical indication, however 30% is for surgical indication. Now, we are talking about PBM in this area. However, majority of pediatric blood gets utilized for the medical indication. If we see what is the demography of patients, so majority of patient that needs in pediatric age group that gets blood is from the age group of 5 to 12, which receives nearly 25% of blood that is collected and provided to our kids. And if you see the history of transfusion, so nearly 60% of these recipients are multiply transfused. So they are receiving not just one but multiple units of blood. So is there some area where we can actually focus? So this is more detailed analysis for surgical and medical indication based on age. And this dark color represents anemia. So you see that in all age group, majority of indication of blood transfusion is still anemia. However, if you see this color, that represents hemoglobinopathy, which gradually builds up from young age and starts dominating from the age group of 5 years, and that shows that hemoglobinopathy, that is thalassemia, is still one of our major need of blood in this age group of patient. If we see neonatology, again, majority is for anemia, which is followed by, for component therapy, it is need for surgical interventions like cardiac surgery and delayed coagulogram, which is often associated with, with sepsis. Now, going further deep into, comparing hematology versus oncology. So, if you see, red cell need in hematology is dominated by the hemoglobinopathies, whereas in oncology, it is majorly anemia, which is requiring red cell and apart from the other blood components. Coming to the surgical need of blood in pediatric age group, if you see cardiac surgery, it dominates with majority of blood components, which include platelet, plasma, and cryoprecipitate. However, in gastric surgery, which is the second most common indication of a surgical need of transfusion in pediatric age group, majorly for red cells and FFP. So as we see even in India, one of the major indication of transfusion is anemia, and this is the most recent PBM document that was released by WHO, and even they show that in Southeast Asia and in South Asia, one of the most common need is for anemia, which is followed by hemoglobinopathies, and that's the major burden that we are looking. So can we actually implement PBM in hemoglobinopathy? Let's see, I'll try to answer that as well. Coming to next stage of or next part of my presentation is benefits versus risk. So what is the need of transfusion? So it gives you an oxygen carrying capacity, it increases the red cell mass, treats an acute, chronic anemia. However, the majority of low birth weight infants receive 1 unit at least when they are admitted in an ICU, mostly to replace the phlebotomy losses. 10 to 20% of critically ill children admitted to PICU receive at least 1 transfusion. And the red cell transfusion in PICU are associated with 30% of mortality in 8% of the admissions. So not only they are receiving more blood, even receiving more blood is making them more prone to have an adverse outcome. So what is happening globally as far as the adverse is concerned? So a multicentric study in US showed that 3.23 transfusion events are there with 1,000 children that gets transfused. However, if you compare with adults, it is significantly lower in adult. And allergic transfusion is something which is the most common type of transfusion reaction. What has been reported to hemovigilance? So this is the SHORTS data which reports around 7.4% of all reactions that get reported to SHORTS, that is the UK hemovigilance data, is pediatric. What is happening? So up to 10%, that's as per our national hemovigilance program, up to 10% of all our hemovigilance transfusion reaction reports that gets reported to the national program is in pediatrics. So pediatrics patients do have transfusion reactions, and they can be a significant number. So this is something that we also wanted to study, and we did a prospective active with our pediatric team, and this is something that we found, and this is an accepted publication now in Vox, should be out maybe by next week. We found that the incidence of transfusion reaction was as high as 6.6% in overall pediatric population. But there was a very interesting finding that in a first time transfusion reaction, the incidence was significantly lower. That means 1.7% as compared to people who are getting multiple transfusion. So a multiple transfused child has 7 times more risk of having a transfusion reaction. And when we saw the national data that up to 60% of the kids that are getting transfused in our country are receiving multiple transfusion. So there is a significant amount of risk with transfusion with these kids. This is a further analysis that major transfusion reactions were from the age group of 5 to 12, again synchronizing with the maximum amount of blood that gets used, and the majority of transfusion reactions were reported with the platelet transfusion, which is again concurrence with the Western data. This is the national data on pediatric transfusion, in fact international. All the countries and all the places that have published a significant amount of number, and if you see the reports, there is a significant number from 1.6 to 1.7, and there is a difference in type of component and type of study that they have done. So there is still a lot of disparity the way transfusion reactions are reported in pediatrics, and often they are missed and not gets highlighted to the clinical side. Coming to the main parts of my presentation is PBM specific guidelines. So do we have a cutoff? Do we have a number at which we can transfuse? So I'm happy to actually recommend all the residents to go through these 2 trials. So this is a top trial, an ethno trial, which enrolled nearly 2,500 newborns across US and Europe to study what is the correct cutoff to transfuse. And surprisingly and very interestingly, both were independent clinical trials done in US and done in Europe, and both reported same numbers that you can go deep. That means for a critically ill child, significant support, a higher threshold of 13 or a lower threshold of 11. However, a stable older infant, not critically ill, a lower threshold of 7 and a higher threshold of 10 that can be used. So 2,500 kids were randomized across 2 major continents, and they were able to say a lower threshold can be safely used. It reduces transfusion and donor exposure, reduces transfusion associated risks, and conserve blood. So this is something that I would highly recommend for people who are interested in neonatal transfusion to go through these studies. Now, can we replicate this in a pediatric population? So this was a very interesting work that was done by a group called Taxi Cab, where they went deep into each type of indication in pediatrics and see what is the cutoff. And they started with a number of 5, depending whether there's a mass fusion or hemodynamically unstable child versus a stable child. And they actually saw that, transfusing at 5 versus between 5 and 7 and going above 7. And I'm not going deep into detail because of the time and the topic that I'm covering, but I just want to show that, for each indication, they were able to precisely say that, what should be the cutoff that can be used for, journal critical illness, post-operative, respiratory failure, sepsis, non-life threatening, acute brain injury, alloimmune hemolytic anemia, and further ECMO and further critical illnesses. And this is a very interesting work, and I am happy to working with this group again to develop one guideline dedicatedly for LMICs. Now, coming to the last part of my presentation, some PBM rules, which I'm sure has been discussed. I intentionally didn't discuss them in detail because I know pre-operative optimization and intraoperative stuff was to be discussed. So this is PBM. As we know, it's a patient-centric systemic evidence-based approach to improve patient outcome by managing and preserving patients' own blood while promoting safety and empowerment. However, I still doubt patients' own blood when most of my blood is going to thalassemia. How can I preserve the own blood? So this is something that we need to see. These concepts are majorly for surgical scenarios. However, majority of our blood in pediatrics is going for a medical illness. How can we adapt that? Again, this was also presented by Dr. Gopal on the famous 3 E's that WHO also highlighted, that there needs to be ethics with the stakeholders. There needs to be economics, which he discussed very well, that we can save some crores. And then what is the evidence? How deep can we go? How low can we go? And these are some studies which can help us do that. Just as a customary, I just want to walk you through again these 3 pillars as far as pediatric is concerned. So for pillar 1, when we are optimizing the red cell mass, we need to identify nutritional anemia, and we still have anemia as one of the major causes of major need of transfusion. We need to avoid iatrogenic need of blood. We need to pick up high risk group in pediatrics, and then even consider use of erythropoietin. For minimizing blood loss, for an intraoperative work, you can use pediatric size vials, better surgical techniques can be used, antifibrinolytics, and some point of care testing which requires minimal sampling can be adopted. Then for post operative or physiological treatment or tolerance of anemia, you need to have evidence-based thresholds, and as we saw, threshold varies significantly in pediatric age. Restrictive is something that has been proven that it is better. However, I have not discussed restrictive in platelets and plasma transfusion. Again, use of irradiated, CMV safe and leukoreduced blood, and considering single transfusion or aliquot transfusion in this patient. Discussing tranexamic acid, it was also discussed by the speaker before me. Even the use of tranexamic acid has been shown to be safe in pediatrics, and it has been now recommended to be used in massive transfusion protocols used for pediatric transfusion, and various organizations have actually recommended the use of tranexamic acid in pediatrics. Finally, as I was discussing, can we use PBM in thalassemia? This is a very new topic. Recent TIF guidelines, which was released in January this year, actually had a small paragraph, and I had an opportunity to discuss with the author that what they actually meant by using PBM. So they actually meant that they want to offer a personalized transfusion protocol to each thalassemia patient. Informed consent and discussion, because these kids end up receiving many transfusions, is taxing for patients. Starting phenotype match blood since beginning, because we know this is a high risk patient for having multiple allominization and newer drug trials. As part of our consent, who's initiating a transfusion in thalassemia child, now it's our responsibility to inform them the availability of drugs, and even if they have a chance to enroll in one of these clinical trials, to see whether these drugs can be helpful for them. And there are many drugs which, even in our center, we have started with 2 of them, and they're showing a significantly better response. Just to summarize, in neonatology, tiny vials, lesser volume, avoiding unnecessary transfusion, hemoglobinopathy, regular transfusion therapy, allominization prevention and iron monitoring, oncology and BMT, monitoring transfusion reactions, cytopenia, and giving irradiated unit whenever indicated. For critical care, balanced restrictive guidelines for oxygen delivery and perfusion goals, and for surgery, anticipate high blood loss, use of cell salvage, tranexamic acid, and preoperative optimization. I think this is the gist of PBM in pediatrics. We've been trying to work, I work in a pediatric center, and if you scan this QR code, that will take you to a website. It's a dedicated pediatric transfusion medicine website, which is developed by our department since last year. And we try to develop an online resource for education, for guidelines, for various material that you may need to read and to know more about pediatric transfusion. And thank you for your time, and I'll be happy to take some questions.
Thank you so much, Dr. Satyam. You have really justified to the title of your topic, and you have provided us with a plethora of information. And I am sure there will be a lot of questions, and the house is now open for brainstorming session.
Thank you.
Thank you to all our distinguished speakers for that insightful and enriching session. I would now like to invite all our speakers and chairpersons to the dais for the next segment, which is the synergetic brainstorming. To moderate this session, I am pleased to invite Dr. Kshitija Mittal, who is Assistant Professor, Transfusion Medicine, GMCH, Chandigarh. Ma'am is a member of Editorial Board of AGTS, Assistant Editor of 3rd edition 2023 of Transfusion Medicine Technical Manual, NBTC, and BTS Division, and she has 40 publications. She is also a member of Special Interest Group Transfusion Transmitted Infection and Nucleic Acid Amplification Testing of Indian Society of Transfusion Medicine, and a member of ISBT Hemovigilance Working Party. She has been awarded Dr. Harold Gunson Fellowship by ISBT at Cancun 2012 and Malaysia 2022, and J.R. Jolly Award at Transcon 2022 46th National Conference of ISBTI Bangalore. Welcome, ma'am. I would also like to invite Dr. Vijay Kumawat sir, who is Additional Professor Transfusion Medicine, NIMHANS, Bangalore. Sir is MD Transfusion Medicine from PGIMR, Chandigarh, PGD MLS Symbiosis International University, Diploma in Tissue Banking, National University Hospital, Singapore. Sir has a total work experience of 15 years and has international and national publications, NABH Assessor for Blood Centers and Transfusion Services, and Quality Manager for NIMHANS Hospital. Welcome, sir.
So, I would like to invite all the speakers to the dais, please. And the chairpersons. So first of all, I would like to congratulate Ma'am Dr. Geeta, Dr. Daljeet, Dr. Ashish and the entire Department of Transfusion Medicine of AIIMS Rishikesh for such wonderful CME on a very important topic of patient blood management. And I would also like to thank for giving me this opportunity to be a part of this CME. Since morning we have been discussing about patient blood management, how it is about, now it is a matic, which is a patient-centered approach based on evidence-based. So as we have been learning about this morning. So now first of all, the first question is to the anesthesia team. So I would like, as it has been already stressed that minimizing first of all, the minimizing patient's blood loss. It is an important pillar of patient blood management. And sir has already, Dr. Yashwant has taken up in his presentation about the various measures how we can conserve blood. So just an extension to it, sir. How do you decide when to use blood conservation strategies and in what type of surgeries it is most beneficial?
Very right question. How to decide when to go for the blood conservation strategy? There are so many things. This is number one. The first is the patient and the nature of surgery, type of surgery. When we are anticipating a large amount of blood loss will be occurring in the surgical procedure. There are so many surgeries in which there is lots of blood is shed while the procedure is going on. Specifically the cardiothoracic surgery and orthopedic surgeries, especially spine surgeries, scoliosis correction surgeries, where we are anticipating a lot of blood. That is the first thing. Second thing, the patient is having a blood group which is rare blood group, and when we talk about this rare blood group and the availability is the issue, then we can go with this blood conservation strategies in this patient. And third thing, not only the surgical procedure on which our decision will be based on, type of surgery, nature of surgery, and our anesthesia technique we apply accordingly to that one. That is all what we can probably start in our blood conservation strategy.
Thank you, sir. Furthering to what Dr. Payal has said, I just want to say one thing. There are certain surgeries that in my institute we are doing. We are going in very frequently for a cardiothoracic surgery where the blood consumption is much more higher. But apart from the non-cardiac surgeries, the other very common surgeries that we are doing is scoliosis surgery, where there is a lot of blood loss. Facial maxillary surgeries and neurosurgeries are other surgical procedures where we do require a lot of blood. And traditionally, what we have been taught and what we have followed is any time whenever the blood loss of more than 10% occurs in the blood of the total blood volume, you have to replace in a pediatric patients with blood. That is a traditional teaching which has come up. But now what we are doing is, like the formula what was shown by Dr. Payal, the lower limit we have not fixed it to around 10 or 9. We do fix it to around 8. So many times the expected blood loss or the allowable blood loss that we usually calculate is slightly more than the 10% of the body weight. So plus especially in scoliosis surgeries and facial maxillary surgeries, we use a lot of inexorablism. So that is there, so that has really brought down our need of blood in the perioperative period. So these are a few things that we regularly do in our case.
Thank you, sir. So next question again to Dr. Yashwant and Dr. Sanjay. So though we know that it has been extensively covered by the speakers, but still, so we may add on some few more things. So the question original was that how does anemia management and blood conservation impact hospital cost and perioperative outcome? So cost, I think Gopal has covered extensively. He has shown that colors can be shown. So, but definitely how to implement that we have seen the figures that okay, it save cost to the patient, it save cost to the institute, it save costs ultimately to the nation. But what are, like, if as a UG want to start this cost saving measure, how to start, how to go about that? And second, I would definitely like to add on that the perioperative red cell salvage and ANH, though it is from PG days we are reading, but still I don't see much adaptation in our country. So what are the challenges for that? Like acute normovolumic hemodilution or this perioperative red cell salvages. So over to you both, can answer.
Regarding first question, that is cost effectiveness. So we are working in a public sector situation, so we that point. Second thing, the cost effectiveness should be going to the last one when we are considering the safety of the patient. Third thing, what you are saying that acute normovolumic hemodilution. Again, while we are applying this strategy for a blood conservation, for a particular patient, we need to think of so many other factors as well, whether the patient, selection of the patient, and depending on so many other indications in that one. The procedure, how we do it, I already explained in that talk. Yes. We remove the blood from the patient and again transmit back to the patient. But how much blood will be taken from the patient, that is already been decided after calculating the volume. We take into account the hematocrit values, but we don't allow any patient inside the operation theatre to allow blood loss more than 25% or more than 20%, depending on the case scenario in a normal healthy acid rate patient. And we can cut off this limit to a lower side if the patient is having other comorbidity and cannot sustain blood loss at that particular point. So that time we have to transfuse the patient with the blood on a PRBC. So coughs, that is all what your question. And I'm trying to address your question next.
Yes, sir. Can I add something?
Yes, sir.
You're talking about self-salvage.
Yes, sir.
Very good technique. But self-salvage has a very limited indications. Firstly, it can be used in any place where there is no contamination with GI contents. Majority of the surgery, the pediatric surgery that is being done is in those conditions where a bowel is being, so there is always a chance of contamination. First. Secondly, the problem which comes is the equipment is costly. The surgeon should be ready to do that procedure. And the last thing which comes is you collect the blood, you wash, and what you give to the patient is only a washed PRBC. That will only be responsible for increasing the oxygen carrying capacity. Apart from that, all the factors and all is not there in the washed PRBC which is transfused back. So that is the problem with the self-salvage technique. And as far as ANH is concerned, me and Dr. Geeta in initial days, we did try for ANH. ANH again has certain limitations. It's a very good technique. Minimum you should have a hemoglobin of more than around 12 to 14 is what is recommended in the books. You take out the acutely, you give colloid to that, you replace, and then you have to replace back. So suppose I am able to collect 2 or 3 units. The collection is 1, 2, 3, but the donation, the transfusion back is 1. So what happens is, suppose the patient, I am only able to transfuse 2 units. So that 1 unit which I have taken out of the patient may not be used. That is one problem. Second is, many a times, again, a cost factor is associated with that because back collection and all is there. A support from the transfusion medicine is required so that they can come down to the OT. And this procedure itself takes some time. Many a times, a longer surgical procedure, we may not have time or the surgeon may not be ready for us to give that half an hour, 45 minutes or an hour. And the most common problem which occurs is even if we transfuse with colloid so as to maintain the blood volume, there are always and always a chance of hypotension in the patient. Because all the blood volume compensation takes time for the body. So these are the hemodynamic changes are very common. If you are going in for advanced surgeries where you don't want hemodynamic changes to this. So we have to be very cautious whenever we are dealing with this sort of a case. So it can be done in a planned condition. You have to give a stent, both to the transfusion medicine, anesthesia, and the surgeons. It has to be a triangle which should have a very good communication with them. And then we have to think of all these factors before we go in for an arrangement. So we tried, but initially this was not possible because number of case lists are more. They want to do more cases. Bag availability was not there. So then the things slowly and slowly went off.
Yes, sir. Thank you so much, sir.
One more thing I just want to add here, use of self-surveys intraoperatively in a pediatric, specifically neonatal surgery, is practically very difficult, and it is not easy to use that machine for a pediatric patient. The total volume of that patient might be around 200, 300 ml. And if you see that machine, the tubings and the dead space of that tubings of this machine is too much. So most of the blood will be keep on circulating in the tubing only, and it will be practically it is very difficult to get this in an attempt to conserve 15 or 100 and 200 ml of blood, which will be there in that machine only. So that is one practical ability of this machine need to be look into.
Yes.
Thank you so much. Now my next question is to Dr. Latika. So AIIMS being there is a high pressure and it's a high demanding branch. So just another question, do you think there are any specific challenges in managing both clinical care and administrative expectations which are related to this PBM? And does this PBM implementation create an undue burden for the clinician to deliver patient care?
I wouldn't consider as a burden. In fact, if you're a good clinician, you have to incorporate this in your clinical practice. So like I said, a patient is giving you 8 to 9 months for an antenatal, red cell mass to be optimized. If you don't use that opportunity, if you think it's a burden for you, so you fail as, your duty as a clinician is, you're failing on that. Certain challenges are there, probably the logistic issues, because we are prescribing oral iron, we're not sure if the ladies are taking it, because we do have questions to, understand whether they're actually consuming it and tolerating it. But then, like I mentioned in my talk, if we can supplement that by IV iron, that would be a fantastic way of incorporating PBM antenatally. And some challenges are there because it's expensive. A single vial of 1 gram, which costs around 6,000 to 6,500 rupees. In the government setup, getting for our poor patients, we have to admit them and then administer. So that is one administrative issue that we have to go through, but not much of a problem in government setups. But sometimes the AIIMS doesn't cover it. So they're trying to convince that lady, see, either you take FCM or you come back for multiple repeated injections to prove because it's much cheaper. But then she has to visit the hospital at least 7 to 8 times for an entire dose to be completed. So there your counseling works. So if you know that you have to correct anemia, so it is how you counsel her, it is how you counsel her husband and maybe mother-in-law, very importantly, that because they are, I think, a driving force in the management of an antenatal. So it's how you counsel the family, that's also there, but we don't consider it as a burden, it's a part of our job.
Yeah, thank you so much. So that's what the WHO has come up with, that primordial prevention, where the social factor also need to, so that optimally sets in, like classical example in OBG care, where the family, particularly mother-in-law, has to come in and decide. So in continuation with the same theme, though you have covered extensively in your presentation. So your second question, are current obstetric training programs adequately preparing future clinicians to implement PBM, and what improvement would you suggest further?
At the moment, our programs do not cover the PBM as a part of our curriculum. We are very grateful because Gita ma'am and the entire team of transfusion medicine has been trying to tell us about PBM, and that's how we picked up the concept. However, the Federation of International Society of Obstetrics, the FIGO, it has adopted and it has recently brought out the guidelines for PBM. And those similar guidelines for management of obstetric injuries are also endorsed by the NETA and also by the European Society of Anesthesia. So those things ideally should be brought into our curriculum. They are not there in our books as of now. So I think seminars like this would be helpful for that. So the curriculum needs to be slightly more revised to incorporate these methods of blood management.
Thank you.
Thank you. So now we move on to the pediatric team. So as now my next question is to Dr. Satyam. So as you've already stressed upon in your presentation that iatrogenic blood loss is not being very much tolerated by the pediatric population. So how can we safely minimize this blood loss in pediatric and neonatal ICUs, particularly in extremely low birth weight units?
Yeah, so iatrogenic blood loss is one of the main causes of transfusion in this group of patients. So obviously using microtainers or small vials, avoiding unnecessary investigation, going for a lower threshold where you know you can wait. Sharing of samples, this is very important. I need a sample just for a blood grouping, which can even come from pathology after they have done a CBC. So concept of sharing is very important when you're dealing with a preterm newborn, where you don't need to send independent samples to all the lab, and if all the labs can sit together and maybe work on a protocol where they know how, in which sequence can they share one sample and can give you all the results. And then obviously using this point of care testing equipments or even non-invasive equipments for estimation of bilirubin or maybe for hemoglobin. So I think these ways, apart from the cord blood, the delayed cord clamping and cord milking.
So anything, madam, to yes.
One thing I would like to talk on Dr. Satyam being a neonatologist. Actually, we maintain a strict chart that is very essential. Residents have to be sensitized that for a 600 grammer, the total blood volume is only 60 ml. So even if taking 1 ml of blood is amounts to almost 10% of total blood volume. So this is very very helpful to tell them and decide what is the need. One more thing, there is again a way of losses by putting different kinds of tubes. Like you need central lines, otherwise it's very difficult to manage these tubes. Like you need umbilical, venous line, arterial line, invasive blood pressure monitoring, you need peripherally inserted central lines for providing ppm. Each time you put these lines, there is at least 2 to 3 ml of blood loss. You can't help that. So ultimately, each extremely low birth weight neonates, they will land in having multiple transfusions. And sharing of samples is a very good idea, but maybe it is difficult, administratively it is difficult. And most of the time we do micro sampling, like it is from capillaries and just drops of bloods. But again, doing blood culture and all require at least 1 ml of blood. So the main problem is blood loss.
So thank you, ma'am. So again, next question to you. So our current blood center protocol and as well as pediatric pathways aligned to support PVM principles, and what educational resources or training models have proven effective in improving PVM adoption in pediatric and neonatal care?
Like we have on the NICU protocol, I am not in pediatrics, so I've left pediatrics for a long time, so I can't say much. But in our NICU, we have our own unit protocol, and we revise that as the standard guidelines, like TOP and ETNO that Dr. Satyam has said. Earlier it used to be the liberal guideline, and nowadays everybody is switching to restrictive guideline because there are different forms of injury. There are different dangerous terminologies, try. So, and really these reactions occur. It's not that they are written only in books. They happen really in actual practical life. So we use restrictive guidelines, and most importantly we keep a Google data sheet so that no resident can fudge in that to have actual patient care data.
Yes, ma'am. Satyam, you would like to add something?
Yeah, something just to add beyond pediatrics. I think if you go for common cause of or need of transfusion in pediatric is United States. Can anybody guess that? What can be the number one need of blood in pediatric age group in United States?
Anyone from the audience?
Who's looking into articles recently? So, no, in pediatric age group. I'm sure my answer is going to surprise everyone. So it's gunshot injury. So you see the difference of what is causing a transfusion in the Western world versus in India. We are still transfusing for thalassemia because we are not able to control it. So there are different policies, different ways of strategies which they are working on because of their demographic need. And it's high time that we realize what is our need and where are we investing our energy into. We often will get international guidelines which are based on something which they are facing and they're least bothered what is happening in India. So I think for pediatric it is important that it is now proven to go for a lower threshold. It is now important as we saw that most common cause of indication is still anemia and most common cause of anemia in India is still nutrition. So for even example, for a cyanotic heart disease going into surgery, will have a pre-surgery hemoglobin of maybe 21. He doesn't need a hemoglobin optimization, but what he needs is better nutrition for him to get into surgery. So this is what we realized when we work with the cardiothoracic team, that they are often working on nutrition of the child so that the child can sustain. I'm sure our anesthesia team may agree with me, so that they can sustain a cardiopulmonary bypass and a surgery. So in India, our needs, our requirements are different. I really like the presentation that Dr. Gopal presented, nearly 50 articles and none of them were from India. So there is a high time that we publish whatever we are doing, even if it is less or for more, one institution, multiple institutions. Let's have our own data to decide upon our own guidelines.
Thank you so much. So, do we have time to take questions from audience? So, I thank our panelists for joining us for this synergistic brainstorming session. So, thank you so much. Over to yes, sir.
Thank you. I think first of all I would like to congratulate Geeta for roping in our clinical colleagues, and I must thank all the clinical colleagues sitting there till lunch and giving their valuable inputs. And I think this is the time. I think this is the beginning, and I think this would be in a long run an example to all of us that our clinical colleagues are enthusiastic. There were one or two questions which you asked about anesthesia colleagues, that ANH and all those blood loss regarding those things. But you see, now I have seen over the trend has shifted, because previously for bypass they used to require 5, 6, 7, 8 units because there was long circuitries and they have to basically prime those circuits. But now the technology has advanced in such a manner, and that the requirements have drastically gone up. Similarly for knee replacement, for arthroplasty, the surgical techniques that you hardly require blood. And moreover, regarding cell salvage and all, sterility is also a big concern actually, because blood is a very good culture medium, and then of course when you transfuse back, you never know that it may get contaminated, because it's in more or less, sometimes it gets contaminated from the OT operative site or when handling that blood bag and the storage conditions. And another thing is for the neonates, which was being discussed, is yes, that idea of centralized testing, because I think all of us as clinicians or transfusion experts or the laboratory people, because now in our Colony Institute Delhi, they have only one centralized lab medicine. I guess Gopal is area. They have only one centralized, one sample goes and all the tests get done. So I think we need to develop those kind of facilities. That way I think we can reduce the sample handling and errors also, because sometimes what happens, that thing has not been brought out here, the most common cause of incorrect or adverse transfusion events still in world over is incorrect identification of the patient with bedside. So that way we, I think all those things can be minimized, because repeated sampling and all those things can be minimized, and of course the workload, that in turn will decrease the workload also, the resident side also. We have calculated that even when we try to convince our colleagues that by sending repeat requisitions you are unnecessarily wasting the time of your own time, which can be utilized in effective clinical management. So I think with this I thank again, and thank you all for joining us. Thank you very much.
Thank you to all our wonderful speakers and chairpersons for this engaging and insightful session. We will now proceed with the felicitation ceremony of our esteemed faculty for this session. I request our esteemed chairpersons, Dr. Sriparna Basu ma'am and Dr. Sanjay Agarwal sir, to felicitate our speakers. Dr. Yashwant Singh Payal sir. Dr. Latika Chawla. Dr. Latika Chawla ma'am. Dr. Satyam Arora sir. I would now like to invite Dr. Atiram Sharma sir and Preeti Helens ma'am to felicitate our chairpersons.
मैडम ऑर्डर है मैम कि आपको बैठना है
एक मिनट में एक मिनट
I would now request Dr. Geeta Neki ma'am and Dr. Daljit Kaur ma'am to felicitate our moderators, Dr. Kshitija Mittal ma'am and Dr. Vijay Kumawat sir.
एक मिनट हो रहा हाँ हाँ सही है हाँ हाँ अब ठीक है हाँ हाँ बोलिए हाँ हाँ हेलो हेलो हाँ हाँ अभी ठीक है ना कर दिया ठीक हाँ 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 हाँ
ये
all, I now hand over the proceedings to Dr. Amit Chatterjee, PTCC resident, Department of Transfusion Medicine, AIIMS Rishikesh.
उनके तो हो गया, यहाँ से चालू करेंगे और इनके स्लाइड्स कहाँ रखे हुए हैं सबके?
हाँ, अब
ठीक।
शीशे का खोलेंगे,
ठीक।
वहाँ से पहले भी स्लाइड
ठीक है, ठीक 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 ठीक। Thank you, Dr. Megha. Namaskar and good afternoon once again, ladies and gentlemen. We now have something truly special. Stories straight from the frontliners of patient blood management. This session is delving into experience sharing where we shift gears from guidelines to ground level action, from protocols to practical pulse. We all know PBM looks great on paper, but bringing it into daily practice is where the real story begins. And today, we are going to hear just that. Real insights, challenges, innovations, and wins from across the country. So sit back and let's absorb some lessons that are not found in any textbook. To guide us through this meaningful session, we are honored to welcome two exceptional names in the field of transfusion medicine. First, Dr. Anupam Verma sir. नहीं हो रहा है, ये सिलेक्ट नहीं हो रहा है। First, Dr. Anupam Verma sir, professor at SGPGI Lucknow. He has served as Chief Medical Superintendent at Kalyan Singh Super Speciality Cancer Institute, was the first state nodal officer for hemophilia in Uttar Pradesh, and current national academic leadership roles as Joint Secretary of ISTM and Vice President of ATOM. His area of passion include clinical transfusion, patient blood management, hemostasis, and quality control. Joining him is Dr. Sushant Kumar Menia sir, Assistant Professor at AIIMS Jammu, a dedicated academician with over 10 years of teaching experience. He has previously led department at AIIMS Bathinda and played a key role in establishing transfusion services both at Bathinda and Jammu. A recipient of advanced certification in PBM and transfusion medicine, Dr. Menia sir is an active member of major national and international bodies. I now invite our respected chairpersons to kindly take over and lead us into this inspiring stories that we are calling Exchanging PBM Vows, experience sharing through original work. Over to you, sir. Thank you.
उनका नीचे का हाँ नीचे ये वाला
Thanks for the kind introduction. And moving to session 3, now I invite Dr. Ashish Jain. Dr. Ashish Jain is very dynamic, flamboyant, and he has been alumnus of Sanjay PGI right now, our student also. And he has done MD and postgraduate diploma in medical law and ethics from Bengaluru. He is General Secretary North of ISTM. He has more than 35 plus publications, recipient of Young Scientist Award and Professor V.L. Award in 12th Annual Conference of ISTM Mahabalipuram. He is also a recipient of NPTEL, Swayam Government of India Star Award. Very nice CV you have, and he's stated with, as we are told that he was instrumental in designing and writing of the lyrics of anthem of AIIMS Rishikesh also. So over to Dr. Ashish Jain, and I really must, thank Dr. Geeta and Dr. Ashish, Dr. Dalji for this very nice, CME. I'm very surprised by the, use of these words like exchanging PM balls. I just thought that hopefully there is no ring ceremony and all that. So, really nice. First time I'm saying this. So, Dr. Ashish, please go ahead with your presentation.
So thank you, sir. Thank you, sir. So as a transplant medicine specialist, actually, when I joined MD in 2012, and sir, ma'am is both here, and I recall my first experience when I was in MBBS second year and starting the clinical posting, and the first day of posting, experienced surgeon came with the patient who will be operated next day, that you will not need any transfusion, I will handle it, don't worry. And the same patient in the previous night in the posting, I assessed the pallor. This is the first pallor case I assessed. My senior resident shown me in the posting that, though, look, this is the pallor, you have to see that how you can see the pallor. The patient is being operated and surgeon is saying you will not need the blood. So I was amazed that how the surgeon can say that the patient is need blood or not. So even the routine in the practices, I can see that most of the calls, even the patient and camp organizer and patient attendant कहते हैं कि बस डॉक्टर साहब ब्लड रिजर्व के लिए चाहिए, जरूरत नहीं पड़ेगी. So I used to think that what are the predictors? How can you say that the blood will be needed, and how can you say that this patient will need the blood? So I have a question that who will need the transfusion? Who can tell that the patient will need a transfusion at elective operation? भगवान तो बता ही देंगे. The God will tell that this patient has what is the outcome, but unfortunately we cannot assess God directly. Experienced surgeon, experienced doctor. What is unique about this doctor? White hairs, wrinkles. This all can tell. Even the one shadow or maybe that one look of this surgeon can say that he is very experienced. He can tell by his or her experience, any surgeon can tell the patient will need a transfusion or not. So these have a lot of predictors. He has experience of a lot of variables in his life that this patient will need a transfusion or not. And important thing about the statistical analysis, by mathematics we can say that this patient will need a transfusion. Right now the AI, I think AI has introduced in class 3rd recently and by NCRT. So that artificial intelligence era, we can, without any investigation, without any even that analysis of the real analysis, we can have the past analysis and the prediction by artificial intelligence, we can say that this patient will need a transfusion. So currently there is a variations among the institution and surgeons. A patient of a simple operation, even at a hospital, even the government setup, in the private setup of the corporate, the patient, we cannot say that this patient will be transfused in this hospital, this institute. The transfusion decision may vary in real practice. Inadequate protection of intraoperative needs, because the patient may require the bleeding, the kind of surgery, the extensiveness of the surgery. It's depend on the surgeon skills, even that the lot of comorbidity, a lot of factors that can decide that the patient may need a blood intraoperatively or not. And mostly, just I have told initially that I have seen the pallor in the patient. So I have the estimate this patient has the pallor, he will definitely need blood during the operation. So over reliance on the hemoglobin threshold. A lot of predictors are identified. Hemoglobin level, no doubt. Age, more the age, the higher chances of transfusion. Female gender, low BMI. American Society of Anesthesia score of comorbidity, Charlson score, a lot of scores are there. The patient have the comorbidity, have more chances of transfusion. Surgical factor, type and duration of the surgery. Lumby surgery, long surgery, 12 hour, 13 hour, 16 hour surgery. The surgeon anesthetist told that kindly keep the reserve the blood. We are extending the duration of the surgery. That will hint that the more blood is required during the surgery. Anticipation of the blood loss, surgical approach, open or minimal invasive. So a lot of predictive factors that can predict, or maybe that variables among the patients that can tell about that the patient will need a transfusion or not. So statistical method how can we say by statistics that this patient, what is the difference between the patient who is going to be transfused, who is not going to be transfused, and what is the different values of different parameters in these two categories of patients. So simple statistical test like simple t-test, even that ANOVA test, independent t-test, even the non-parametric test, Friedman test, Wilcoxon Sandeng test, a lot of tests we can do, and we can demarcate in two categories, transfused and non-transfused. And we can say the different variables in these two categories. Odds ratio, we have all know about the odds ratio, the presence of the risk factor. So something is present in the transfused category, more or less. Odd 1 means none, nothing, there is nothing significant. 2 means more than 1 is the risk factor is definitely present in this category. Regression analysis, we have seen a lot of regression curve, in even all the articles having the regression curve, regression coefficient value. So this all can tell that this patient, this risk factor or variable is more associated with the transfusion, or this factor is less associated with the transfusion. So now it is an automatic linear modeling is a recent regression, the SPSS software and R software who can know that there is a recent addition of the linear modeling, then can tell about the accuracy of that risk factor associated with the transfusion. Not going to the detail of the statistics, but even that the ROC curve, that is the ROC curve is highly associated with the sensitivity of any risk factor that is associated with the outcome. Machine learning algorithms, random forest, a lot of neural networks, a lot of computer softwares are coming that can tell about that the patient will need a transfusion. So outcome is any patient that need more than 1 unit of RBC or 1 unit of RBC perioperatively, maybe during operation or after the operation. So I took some predictive factors from the studies like hemoglobin less than 10 is associated with the odds ratio of 5.2, means around 5 times more in the transfused category. Older age, female sex, low BMI, comorbidity 2.1 means more in the transfused category. Major surgeries, odds ratio 4.5. So it depends on this factor, major surgery in the transfused category is 4 times more associated with as compared to the non-transfused category. So some data I have collected because I love statistics and I love to play the data. The more data, it's a kind of addiction that the more analysis you will do, you will find more models to analyze. So some data I have collected retrospectively from a neurosurgery department. So 224 patients and the 6 types of surgeries and 3 different surgeons were compared. The predictors were taken baseline hemoglobin difference, that is the post-operative versus pre-operative hemoglobin. Ideally the blood loss should be taken, but it is difficult to take the blood loss because for that the OT note should be reviewed. But this all data is available in the e-hospital, so that I can easily take. Surgical indication, surgeon, age, gender and presence of comorbidity in the discharge note. In the transfused category, the mean hemoglobin was 10.34 and in the non-transfused category, mean hemoglobin was 11.71. So there was no statistical difference, but the difference in hemoglobin was more in the transfused category. Okay, and age, generally neurosurgery has the trauma, so that the having a less age, but in rest of the in the literature is found that the higher the age, the more chances of the transfusion. So this cross tabulation, I think you can see that by the diagnosis you can say that it depends on the diagnosis also. Like traumatic trauma cases, aneurysm, they have the more in the transfused category. Brain tumors, spinal surgery, they have the more in the non-transfused category. So depend on the type of the surgery, we can do this analysis anytime. It's a long, more the data you can have the more number of diagnosis, more subcategory of diagnosis, and even the different classification of a diagnosis. So this it can be analyzed easily. And about the surgeon, जो बात आई ना शुरुआत में, वो surgeon say that he patient, even that it's common among the patient कि blood less surgery is done by this surgeon. So this surgeon is very less blood is transfused. So it depends on the surgeon also, that some surgeons may prefer to take a higher threshold, some prefer to take lower threshold. So it depends on the surgeon also. In odds ratio, that hemoglobin was of less than 10 is 3.62, so that around 3.62 times that the transfused category hemoglobin less than 10, comorbidity 2.6, age greater than 6'5", because for that I have excluded trauma cases, so 2.1, and female gender is 1.2 times. So I have also done the regression analysis by linear modeling and show that what is the accuracy of preoperative hemoglobin. So I think anybody can tell what is the probability, transfusion probability when we say this is significant. I think nobody want to answer. More than 50% is when we say that this is actually the accuracy, or maybe say that the transfusion probability is greater than 50%, then we can say that the patient will need maybe land up more chances of transfusion. So only the preoperative hemoglobin having the accuracy of 23%, and hemoglobin post-op versus pre-op is 35.9%. But when we take both preoperative hemoglobin and hemoglobin difference, the accuracy land up to 60.7%. So this statistical analysis can say that the patient having the low hemoglobin and the more hemoglobin difference or more chances of the bleeding, that is the more probability of getting transfused. And when we compile with the gender, its accuracy is increasing, or more factors like presence of comorbidity, 75%. So this kind of analysis, the purpose is showing that by statistical analysis, मे बी महादेव से कहने से पूछने से हम बच सकते हैं, भगवान से कहने से, और मे बी दैट द एक्सपीरियंस observer, maybe subjective difference can be avoided if we are doing some mathematical calculation or statistical analysis. So we can predict that this type of patient will need transfusion, this type of patient will need not transfusion. So what is the application of this? The PBM. It was even most of the literature, even that is that to categorize the patient category that will need the real PBM implementation, because a wider implementation or generalized implementation is real-time difficult task. So if we find out a category of patient that is highly beneficial and maybe have the more probability of transfusion, that if we target this population, that the PBM concept can be more justified. Even the counseling and the type and screen and type and cross match policy can be used by if we are doing the good probability analysis, and importantly resources optimization. So limitation and challenges is that this data analysis is complex. Actually, we have to take a lot of patience in entering the data, analyzing the data, and selecting the data. Okay, and the population difference may be there because it depends on that. Even in my center, we can say that this patient may be a craniotomy, leave a less probability, but maybe in some other center they have a different approach or different technique. So this patient will need a different kind of transfusion probability. And surgeon variability, intraoperate events are unpredictable in real time. So future direction is incorporate real-time interoperative data, artificial intelligence. So what is AI? I think AI is though actually been yes. So next news coming. So okay, AI is very important to tell that this is the last route. That the more the data, so that even the filler in the vacancy of the data can be filled by AI. So okay, so one multi-central collaboration is needed for that further analysis. Or patient-specific PPM dashboard can be implemented if we are having the good probability of patients who are requiring the transfusion. So these are the references. Thank you.
अब बारी है एक बहुत ज़रूरी इम्प्लीमेंटेशन का लंच ब्रेक. So we'll meet after 1 hour, 3:15 sharp. Thank you.
लेके आओगे हमें दे दो वो काम देगा प्लीज सोवेनियर्स दे दो सारी प्रिंटेड हाँ वो प्लीज और ये दीपाली जैसे उसमें ये ट्रीज का क्या सीन है इसकी पढ़ी है शर्मा सर उनकी है ना
ये तो शर्मा सर प्रीति मैम और शर्मा सर का सीन
हम सब ले गए बुक्स कोई भी नहीं
बुक्स नहीं है
मैम इधर बॉक्स में आया सब ले गए
മോണിറ്റർ
ഇല്ലല്ലോ
Our session 3, and Dr. Anupam sir and Dr. Sushant sir, if you please take over from here, sir. Thank you.
Very good afternoon, everyone. Before introducing our next speaker, I would like to thank Dr. Geeta ma'am, Dr. Ranjit ma'am, Dr. Ashish for inviting me over here. This is AIIMS Rishikesh has been very close to me because I have worked there for more than 4 years. It is just next home for me. It is the second home for me. So now I would like to introduce our next speaker, Dr. Daud. So it has been a great journey for Dr. Daud, who was resident over here and who has become now assistant professor at AIIMS Bibinagar, Hyderabad. I had the privilege to be his co-guide also during his residency. So Dr. Daud is working as assistant professor in Department of Transplant Medicine at AIIMS Bibinagar, Hyderabad. He has done his MD Transplant Medicine from AIIMS Rishikesh. He has been member of working parties clinical transplant in social media, education and life threatening subgroup science meeting. He has been joint secretary Transplant Medicine Academic Society, that is TAMAS, ex-editor Transplant Medicine Academic Society, core organizing member for various national and international CMS conferences, co-guide of multiple postgraduate thesis projects and PhD project, trained in competency-based medical education for faculty in Transplant Medicine, Transcomed 2023, Jipar Pondicherry. Now I would like to invite Dr. Daud for further proceedings.
Respected dignitaries, faculty members, and my dear colleagues. First of all, I would like to thank Geeta ma'am, Daljit ma'am, Ashish sir for providing me a wonderful opportunity to share my insights on a topic which is novel and very much of age. It's about a development of an AI chatbot using large language model for patient blood management, a simulation-based prototype evaluation. So first of all, my team members, even though the idea is mine, the technical expertise and everything was provided by Arun Vijay, Assistant Professor, Malabar Medical College, Calicut, Kerala, and my HOD, Arun Rajendran, HOD AIIMS Bibinagar, Hyderabad, and Dr. Ashwin K. Mohan, Senior Resident in my own department, AIIMS Bibinagar, Hyderabad. So I would start with about patient blood management and like what it is, like what are the 3 pillars of PBM and all. Whole day like we were explaining in detail, so I'm not boring you with my 2 cents on that. So coming to the challenges, various challenges in patient blood management, we know that like we are using a lot of guidelines which are like very complex, very nuanced from the like international guidelines. So, and like there will be some decision fatigue among the clinicians whenever they will be meeting with a lot of decision set points that will lead to a deviation from the standard or current practice, like the ideal practice. And you know that like there are knowledge gap among the clinicians, because we all know that like in the UG curriculum, we have not been taught transfusion medicine extensively. So those like people who are still in clinical departments may not be aware of a lot of things which is coming new to our branch, like regarding like patient blood management and things. And resource constraints, we have to talk about resource constraints in a country like India, a developing country like India. So still we don't have a unified patient blood management guidelines. So coming to my topic, artificial intelligence as a solution for PBM challenges. If not for all, at least for some of it, like we can, the artificial intelligence has emerged as a solution. So why artificial intelligence? Because its ability to process complex guidelines and present contextualized recommendations. Just like if in Google, if we have to search, like you have to put some search terms. According to that, they will provide closest information. But in a artificial intelligence era, if you provide a scenario, it will be giving directions based on the context. And 24/7 availability if there is a good network, and consistent application of evidence-based practices. Whatever data we provide, like the latest guidelines, if we give, it will work fine. So it will be, they will be answering according to the guidelines or data set we provide. Just like instead of, if we go to ChatGPT or Grok or any other chatbot models, artificial intelligence tool models, they will be taking data from all over the internet. So they will be giving some nonsensical data. They will be giving non-existent references. So we may get confused and like it will lead to a lot of chaos. So if it is very concentrated, very focused on the topic provided, if we have a PBM bot only which will take data only from the guidelines we provide, then it would be a better alternative. And potential to learn from and adapt to new evidence. This is also a very important point, because if you ask the AI tools, chatbot, today one question, and if you repeat the same question after 30 days, the responses you get will be different. Because the AI chatbot, it will learn from us. It will learn from the feedback the humans provided. So, and standardization of care across different clinical settings. If we implement this chatbot in a uniform manner, it can lead to standardization of care. So our aim was to develop and evaluate an AI-powered chatbot trained in internationally accepted PBM guidelines to assist clinicians and transfusion physicians alike. So like it involves development, simulation, like we will be testing with some 10 diverse clinical scenarios related to PBM, and that we have taken from the textbook of AABB, transfusion, hemostasis, and apheresis. And then evaluation, assessment of this chatbot responses through objective evaluation, because we took this book because multiple choice questions, and so like there will be an objective evaluation possible rather than subjective variation in the assessment. So coming to the chatbot development, first step was like data collection that we have taken from majorly from 4 guidelines. That is first one, AABB guidelines, then from Australian Blood Authority, and then from National Blood Authority Australia, and BCSH guidelines and NICE guidelines. These are the 4 guidelines we used, and we have uploaded to our database. And second step was AI model selection and training. We have used a large language model which is Claude Haiku 3. That is like not an advanced version. It is still a like very basic version, but still we have a like potential of developing into higher models and higher versions. So still we have done a lot of fine tuning in the domain specific content, like whatever we have scenarios we have provided, like based on that, like we have done a lot of fine tuning, because whatever we have to do this restrictions which we place on the chatbot, because if we allow it to freely act, it may tell you some nonsensical things and all. So we have to put some certain restrictions. So for that, like we have to do a lot of fine tuning. Then interface development. The interface should be very smooth between the clinicians and the chatbot. So these are the like major clinical scenarios which we have taken from AABB textbook. And that is that I think like we have almost covered almost all parts of PBM, preoperative anemia management, massive hemorrhage protocol, pediatric management, and transfusion concentrations in hemoglobinopathies, management of transfusion reactions, almost wide variety of segments we have covered. So like this is how it looks like. So this is an example like we have put, like this is about a 67-year-old woman with rheumatoid arthritis. We were asking, like we were giving hemoglobin, ferritin, and all those things. Finally, we were asking like she needs 2 units of PRBC transfusion. Should blood be released or not? So the chatbot will be giving bullet points that quoting different guidelines which we have provided, AABB guidelines, NICE guidelines and all. Finally, in summary, it will give one suggestion like this. I'm not telling you to blindly follow the chatbot, like, but it will be acting as a support tool. You can only take it as a support tool, not as a like decision maker. So this is another example, like this is a case of BMT and about the platelet transfusion. So like what is the appropriate step? So they're also same, like the pattern will be similar. They will start with ABB guidelines and adequate references, like you can cross-reference the guideline. That also like it will be providing. Finally, as a summary, like it will tell you whether to proceed it or not. So like that, like we have, like I have quoted some 2-3 examples only. So coming to the discussion, implications of practice. What are the strengths? Like if we do use this artificial intelligence tool, what are the benefits which we can get? Because we can get a like holistic idea of what all guidelines are available at this particular scenario. For this particular scenario, what can be the plan of action? So they will be quoting all these guidelines. And there will be consistent application of evidence-based recommendations and potential for 24/7 decision support. As I said, like if good network is there, it can like continue. And detailed citation of guideline sources. It will be quoting, the references will be there, you can cross-reference always. And limitations, you know that like it can never replace humans, at least at this point of time, like we cannot. So whatever scenarios we have tested, we can say that like almost like 60 to 70% accuracy we have found, and we are still fine-tuning it. Like it is not in a final version. It is still in elementary stage. So we can do a lot of things. And now also like we will go on with the evaluation and all. Now we have not done that. Just 10 clinical scenarios we have taken, and we have taken the responses from the textbook and we have compared the responses, whether it is giving the right answers to the multiple choice questions or not. So still like if ABB guidelines say something and NICE guidelines say something which is different, like the chatbot can be getting confused. And like and again about patient preferences, that also like it has least concern, because it will still suggest blood transfusion to a witness patient. So these things only clinician can do. Even with the support of this clinical tool, it cannot replace. That is the bottom line. So it represents a promising clinical decision support tool, but cannot replace clinical judgment and human expertise. But you are as good as your tool. So if you have this tool, like you can perform better. That is something like we can say with certainty. So the biggest takeaway from this point is it can still effectively support clinical decision making, but it cannot replace humans. And next step, what we will be doing, now we have just analyzed the multiple choice questions only. So we will be using a lot of other questions. We will be using statistical methods to analyze. We will be giving it to the transfusion medicine experts, and we will be comparing our chatbot response to the transfusion medicine experts' opinion, or like their answers, responses. And we will be fine-tuning on basis of that. So this is our plan. Like I wanted to like present it just as an idea, but I think it is still in primitive stage that I have to tell again and again with a disclaimer. But still, I would like that this is not, I'm not just bluffing. So I just wanted to show, like if it is possible, I can show a live demo, but it is still a like infant, not even infant, it's a neonate. So please don't harass my neonate. So but still I will just show you that like it works. It's not that like I'm not bluffing, it's work. So I would like to show like one link. So this is our chatbot. Like this was a case like we have just put a 20-year-old male patient posted for hip surgery, hemoglobin 7.8 gram per deciliter. I'll just show you the. It's not coming up. Oh. इसका स्क्रीनशॉट लेके डाल सकते हैं. Directly will not come up. No. Can we just
इसका ये ना हम लोग इसमें नहीं है, पीपीटी में नहीं है, ये ब्राउज़र है. तो
So I would like to show like if it was feasible. It's not coming there. Nothing, like it was just a live demo, like how it works, like what all prompts you can give and like how it answers. Okay, like we will, I think if it's taking more time, like we can work it out behind the screen, and when it is about to come, like I'm always ready, I'm here, I'll be here only. So.
On here. Don't come up. आपका ये स्क्रीन जो है वो मिरर नहीं हो रहा है इधर.
Okay, if it's taking more time, like we can do it later. I am there, so.
एक मिनट. It's coming. ना आपका ये हैंग हो गया है बस. आपका ये हैंग.
I think we can move to.
Yes, sir. No issue.
एक और connect करके.
Dr. Vadehi, Senior Resident, AIIMS Delhi.
हैंग हो गया. लैपटॉप नहीं आपका ये हैंग हो रखा है. हम लोग इधर से जो शो कर रहे हैं वो चल नहीं रहा है. मैंने लैपटॉप तो चल रहा है. क्या चलो अब ड्रॉप करो.
Dr. Vadehi Prasad has done her MD classroom medicine, and presently she is working as senior resident at All India Institute of Medical Sciences, New Delhi, and she was award winner for the presentation at AIIMS Congress Muscat 2024. She has presented more than 10 oral and poster papers in international and national conferences, multiple format index publications on medium to new pathology and accuracies, and actively involved in mentoring MBBS and postgraduate students. Strong advocate in medium and quality systems in customer services. Dr. Reddy, please.
Very good afternoon to all. Myself, Dr. Vadehi Prasad. I would like to take this opportunity to thank all my teachers for giving this wonderful opportunity. So, from morning we are hearing about what is patient blood management, what are the benefits, how do we implement the challenges, the risk associated, etc. Our faculties also shared their experience. Now, I would like to share our experience as a team in Rishikesh, where we implemented patient blood management program for platelet therapy among hemato-oncology patients. So you will be thinking, why platelet therapy? Why for particularly hemato-oncology patients? So as we all know, when we see the transfusion population among the patients, it will be most commonly hemato-oncology, and they will be mostly receiving RDP or SDPs. So when we see our guidelines as well as RCTs, we could easily see that Platelet transfusion triggers randomized control trials are very rare, mostly 2 or 3. But when compared to RBCs, it will be more than 8. So I would like to share our experience right now. So we all know what is the need of implementation of PBM. We have already discussed that there is only prudent use of transfusion only when required. So ultimately, we are reducing the transfusion load over the patients and thereby the risk associated with this. Mainly the allogenic component and thereby platelet refractoriness. So the patient safety is the main key here. And is there any need for a regular audit here? So we will be doing transfusion to all the patients whenever it is required, and we'll be continuing our own practices, but we are not checking whether we are doing it right or not. So in order to reduce any unnecessary transfusions, we should do regular audit, and thereby we can understand whether we are following evidence-based guidelines, and we can actually evaluate the effectiveness of the practices. So what is the main challenge? The main challenge is the lack of awareness, especially among the medical professionals as well as the patients. So what we can do for this? We can combine all the stakeholders, especially the doctors, nursing officers, technical officers, the patients, the hospital administrators. Everyone should be aware of the PBM. So how to implement it? As we have already mentioned, gaining knowledge is the most important thing. So through thorough data gathering and effective interaction with the diverse stakeholders will help in implementing. So how will it change it? So there will be an attitude change as well as structural modification and resource allocation for the right patient, for the right transfusion, for the patient safety. And through this, we can also formulate hospital transfusion committee for the smooth practices of PBM. So the study we conducted was in AIIMS Rishikesh in 2022. So we collaborated with the Department of Hemato-Oncology, and our main aim was to implement an effective PBM program for platelet transfusion therapy. So the primary objective was, first, we made a team. So that team was named as platelet transfusion practitioners. So it comprised of doctors from both the department, the nursing officers, as well as the technical officers. And second thing is, we trained and educated them. And third thing, we studied the appropriateness of platelet transfusion mainly through audit. So coming to the secondary objective, we mainly focused on what is the effect of this platelet transfusion, mainly through CCI calculation, and we also took the feedback from all the clinical end users to analyze. So the methodology was a simple quasi-experimental study. It is not a new term. It is basically, in simple words, it is basically a true experiment without randomization. So this was a one-year study. We divided the phase into 3, a pre-intervention, intervention, and a post-intervention phase. So during pre-intervention, we did an audit as well as a component stock assessment, and also we followed each requisition form with bedside transfusion practices and 1 hour CCI count. And also we took a survey of all the stakeholders, whether they know regarding the platelet transfusion practices, especially their self-perception, knowledge and practice. Same thing was done in post-intervention, and during intervention sections, multiple interactive educational sessions were given. So in the end of the post-intervention, we took a feedback. It was basically made of Kirkpatrick's model. That means we asked their reaction, how did they feel, how did they learn, and what was the impact on these sessions and the results. So these were the interactive educational sessions we were given. So that time, now we have ABB guidelines, which is like comprised. So when we were doing this practice, we never had a formulated guidelines. So we made a pocket book out of it, and also we displayed the platelet transfusion practitioners as a poster. So coming to the results, I am first going to the audit results. We received 556 requisition form, 254 were during
coagulation monitoring is required. Thank you.
Next presentation, we move to next speaker and we take the questions that were questions. Our next speaker is Ms. Arthi Kumar. She is a resident of Field Technology First Year, Department of CTS in Rishikesh. Her areas of interest are electrical cell salvage, patient blood techniques, clinical techniques in cardiac surgery, clinical surgery, cardiothoracic surgery. She has been awarded as University Rank Holder in BSc Field Technology, Chittor, Pondicherry. You can start with your presentation.
This one, right?
Good afternoon, chairpersons, faculties and delegates. Thank you, ma'am, for this opportunity. And today I'm honored to present our original work. That is sepsis. Intraoperative cell salvage in neurosurgery, a case series. So I hope everyone will be having an idea about what is cell salvage. So for those of you wondering what is cell salvage, it's an autologous transfusion technique where we will be collecting and reinfusing patient's own blood intraoperatively. So it reduces the allogenic blood transfusion. Collection phase. Here in this collection phase, we'll be collecting the blood through a dual lumen tube, where in one lumen anticoagulant will be running and in other lumen shed blood will be. And with the help of vacuum in the collection reservoir, we'll be collecting the blood, and the reservoir has inbuilt filter which will be filtering the debris from the blood, and later with the help of the roller pump over there, we'll be collecting the wash solution and collected blood, and it is sent into the centrifugal bowl, and with the centrifugation process, the centrifugal bowl separates the RBC and debris. It will be working under 5,000 to 6,000 RPM, and the collected debris will be going into the waste bag, and the blood will be reinfused in the reinfusion bag, which can be used for the patient. So this is the cell saver machine. The first one, it shows roller pump, and here we can see the centrifugal bowl. Here we can see the centrifugal bowl, and this is our assembled circuit. Surgery. For a week in our OT, we'll be using two times. Mostly we'll be using for op cab, that is off from coronary artery bypass surgery. And we can also use in other specialties like neurosurgery, trauma surgery, vascular surgery, obstetrics, orthopedic surgery, and even in transplant like liver transplant and kidney transplant, where we expect more blood losses, and in pediatric surgery also recently, because we are even getting pediatric circuits with pediatric bowls. Implementation benefits: it reduces allogenic transfusion and it is cost effective in nature. It reduces the risk of infections, and it is quickly and readily available. We can assemble the circuit within 2 to 3 minutes, and it has more viable and potent RBCs, and it has decreased potassium content. Of course, it has certain limitation like hemolysis. If we apply more negative suction, it can cause trauma to the RBC, and dilutional coagulopathy. If we use more wash solution, it can cause dilutional coagulopathy, and even the clotting factors are washed away while we are washing the blood, and it can be used only when the loss is greater than 1000 ml. In case of ruptured tumors or gross contamination we should not use cell saver, and it is strictly contraindicated in sickle cell disease. More formal training and simulation practice is needed for wider application across specialties. So coming to our diving to our original work, our aim is to highlight the intraoperative usage and outcome of cell salvage in patient blood management in neurosurgery. So here we present a case series which includes 2 cases which was done in Department of Neurosurgery in collaboration with Department of CTVS, AIIMS Rishikesh, a tertiary care center. Speaking about the case 1, our patient is a 40-year-old female. She's been with residual left CP angle meningioma. She's been previously operated elsewhere, and when she was admitted, her preoperative HB was 13.6 gram per deciliter, and intraoperatively it dropped to 11 gram per deciliter. So we set up the cell saver machine on standby, and we collected the blood. But intraoperative, the bleeding was minimal despite anticipated risk from adhesions. Then we collected the blood, but we didn't reinfuse the blood to the patient. Postoperative course was uneventful, and there was no transfusion required for the patient. These are the intraoperative images of the patient. And case 2, we have a 17-year-old male. He'd been diagnosed with foramen magnum meningioma, and his preoperative HB was 13.2 gram per deciliter. Intraoperatively, he had significant bleeding during tumor dissection, and the blood loss was around 1000 ml. So immediately we set up the cell saver circuit within 2 to 3 minutes, and we collected the blood, and we reinfused the autologous blood back to the patient. So we reduced the allogenic transfusion, and he had a very stable recovery. His total hospital duration was 10 days, and ICU stay was around 2 days for observation, and he doesn't require any ventilator support. Looking into his HB trend, preoperatively his HB was 13.5 gram per deciliter, and intraoperatively it dropped to 9.7 gram per deciliter. And later we infused around 464 ml of blood, where 240 ml is from the cell saver machine and 224 is allogenic blood. After that, post-transfusion, his HB raised to 12.2 gram per deciliter. So when we compare between the allogenic transfusion and the cell saver autologous transfusion, in cell saver there is no risk of cross-matching error or immune reaction, and we doesn't have any risk of hypocalcemia because we doesn't use citrate for anticoagulant. We use heparin, and the infection risk is minimal because we are using patient's own blood, and it is in a closed sterile system. Group typing and cross matchings are not required. It is quickly and readily available in the OT. We can be immediately processing and reinfusing the blood when we encounter major bleeding. And speaking about 2,3 DPG and ATP levels, it is depleted in stored blood, which can lead to decreased oxygen delivery, but it is preserved in the cell salvaged blood, where we can provide immediate delivery to the patient, and the cells are less viable in stored blood compared to the cell saver blood. Here the cells are more fresh, and we can be reinfused within hours. Speaking about the cost, it is cost effective in nature in case of high blood loss surgeries, and it is more acceptable to JHOS witnesses. My take-home messages are: intraoperative cell salvage is safe in neurosurgery for patient blood management. It is cost-effective and quickly available. Complications are rare, but it requires vigilance. Operator training is the key for its maximum application across specialties. We need to watch for rotum and TEG in case of dilutional coagulopathy. And I strongly believe that we can maximize its usage across specialties like obstetrics, onco-surgery, orthopedic surgery, etc., where we encounter more bleeding. And to summarize, Cell Saver complements patient blood management. It is a tool which has to be used judicially to reduce unnecessary exposure and conserve precious blood resources. These are my references. Thank you.
Very nice presentation. We should be moving to the next presentation, I think. This is the last time. Our next speaker is Mrs. Aswathi A.R., Senior Nursing Officer, Department of Transfusion Medicine, AIIMS Rishikesh. Her areas of interest are therapeutic warfares, patient blood management techniques. Experience is 14 years of clinical experience, 1 year teaching experience also. And she has done other certified courses like ACLS, BLS, ACTN. So you can start with your presentation. This one, right? Okay.
Good afternoon to everyone. Being a nurse, I would like to share my experience in the domain of transfusion medicine. As in recent years, as the brand transfusion medicine is advancing, our nurses' roles also transforming. So here, we can discuss some expanding role of nursing officers in modern blood bank and transfusion medicine. It is a pilot study. Please consider it as a trial run. With rapid advancement in transfusion medicine, the role of nursing officers has evolved beyond routine support to encompass critical decision-making and patient care responsibilities. Aim to highlight the evolving and critical role of nursing officers in modern blood banking and transfusion medicine, focusing on patient safety, efficient care, and donor engagement. Come to the objectives. To define the key responsibilities of nursing officers in transfusion services, to demonstrate the role in emergency triaging and transfusion safety, to showcase the involvement in donor counseling and education, to underline their contribution to quality assurance and audits, to encourage professional development through training and clinicals. Methodology, focused group discussion. As I told, it's a pilot study. The number of participants were 20, among that 7 nursing officers and 13 doctors in transfusion medicine, AIIMS Rishikesh. The salient points were noted. Most of the participants felt that the expanded roles are triaging emergency versus routine blood issues, counseling patient attended on donation and transfusion queries, maintaining communication with the ward staff, managing adverse transfusion reaction and issuing blood components, and training nursing personnel. Here we can more focus on the practical side so that we can improve the quality of patient care. Not only the quality of patient care, but also it strengthens the safety and sustainability of our blood supply chain. Conducting clinical audits of transfusion practices, operating a nurse-led follow-up clinic for the deferred and repeat donors. After a trial run, we come to the result that improved patient safety through proactive nursing roles, higher satisfaction among the donors due to effective counseling, better documentation and cold chain maintenance, successful handling of adverse transfusion reactions, greater nurse-led initiative in donor retention. Limitation of this study, less number of participants and statistical analysis not done. The future scope for the study with more participants, we can include the participants of other department also. Let me conclude. The expanded role of nursing officers ensures safer transfusion practices. They provide essential support to both donors and recipients. The training and auditing effort maintaining high standards in care. Their presence in clinical enhances continuing quality of services. Nursing expertise is indispensable in modern transfusion services. We thank to the administrators encouraging training and training initiatives, appreciation to our faculty, technical staff for continued support, gratitude to all voluntary donors and patient caregivers. Special thanks to the nursing staff of transfusion medicine. Thank you.
Very good. In fact, I'm really happy to see the last two participants, and I mean, their role should be acknowledged. I mean, they are the transfusion nurses who are there in the ward, and they are actually giving this transfusion to our patients. And I mean, all kudos to you, for bringing all these people on the stage. Very good. So if there are, so if there are any questions. Okay, I have just one comment. There's your doctor was talking about chatbot, AI, Dr. Daud. So if you have, advanced some model of, this chatbot, and if we have artificial blood, I think our branch will not exist in the future. Thank you so much. Thank you. We can wrap up.
So that brings us to the end of session 3. On behalf of the team, we thank all of our speakers for sharing such honest and practical experiences. We now request our respected chairpersons, Dr. Anupam sir and Dr. Susan sir, to kindly felicitate our speakers. First of all, Dr. Ashish Jain sir. Next is Dr. Daud sir. Dr. Vaidhi. Dr. Priyanka. Ms. Aarti. Ms. Aswati. And now it's our turn to express gratitude to our chairpersons for leading the session so smoothly. May I request Dr. Meenu Vajpayee ma'am and Dr. Lalit Dantole sir to kindly come forward and felicitate our chairpersons, Dr. Anupam Verma sir and Dr. Sushant Kumar Minia sir, on behalf of the organizing team. So thank you all once again, speakers, chairs, and our wonderful audience. So now, Dr. Priyanka Rathod, final year PG resident of Department of Transfusion Medicine of AIIMS Rishikesh, will take over here onwards. Thank you.
Thank you, sir. Good afternoon, everyone. So let's get up for a highly interactive session. And as we move on from 3 years in our discussion of patient blood management, this session is dedicated to real-world implementation and translating guidelines into action and teamwork into outcomes. Let's begin our session 4, stepping into the real world of PBM implementation in the hospital. To chair this session, it's my privilege to welcome respected chairs for this session, Dr. Manish Raturi, sir, Professor, Transfusion Medicine, Himalayan Institute of Sciences, Uttarakhand, Dr. Nidhi Keli, Additional Professor, Emergency Medicine, AIIMS Rishikesh. Dr. Manish Raturi, sir, is a professor in Department of Immunohematology, Swami Rama Himalayan University, Dehradun, India. Sir's achievement is 12+ year teaching experience and clinical experience in transfusion medicine. Professor Associate and Assistant Professor roles at SRHU, MAHE, Manipal, and AIIMS. 106+ publications, BCHS Travel Scholarships, United Kingdom, 2024 and 25, Global Investigator Award, Korean Society of Laboratory Medicine, 2023, 14+ national and international grants and awards, gold medalist in MBBS, editorial board, Transfusion Clinic of Biology, patent holder, and expert in biosafety, hemovigilance, rare donor registry, apheresis, and immunohematology. Now I'd like to request Dr. Manish Raturi sir to introduce our speaker for the session.
Dr. Manish, everyone has read my introduction. If you don't mind, I'll start. Is it okay? No, they've read though already. So it's a proud privilege to introduce my mentor in a way, and my teacher also, Professor Geeta Negi ma'am. She is Professor and Head Department of Transfusion Medicine and Blood Bank, AIIMS Rishikesh. And Madam has been a FAMER Fellow from 2014. She's a chairperson, mentor, and medical humanities unit also she's headed. She's done vast work in the field of transfusion medicine with lots of achievements and awards. And one of the awards that I would like to highlight would be Best Teachers Award from Chief Minister in 2013. And that was, I think, in Himalayan Institute, ma'am, where I'm currently working. And she's also been awarded Best Teachers Award at AIIMS Rishikesh in 2021. And also Him Ratna Award from Governor of Uttarakhand 2020. So it's a proud privilege to welcome ma'am. So can we have a huge round of applause, please? Thank you.
So good afternoon, good evening to everybody. So coming to the continuation of what we saw in the morning. So how many people remember that role play? Show of hands. Because if you don't remember, then they'll do it again. You all remember? Yaad hai na? Okay. So we'll continue. So if there's anybody who was not here in the morning, I'll just quickly revise. So there was a poor patient called Mr. Asahai. यहाँ बैठे हैं Mr. Asahai. इन्होंने अभी हाथ खड़ा किया. तो इनकी surgery होनी थी. And what happened was that the anesthetist and the surgeons, they were really insisting on blood transfusions for him. And he didn't want. तो आखिर में वो माने नहीं एंड इन्होंने भगवान भरोसे वाला एक ऐसा जेस्चर किया. अब तो भगवान ही जाने क्या होगा क्योंकि खून भी चढ़ रहा है, सर्जरी भी हो रही है. सो नाउ आफ्टर दैट व्हाट हैपेंड दैट now I have some more characters to introduce. So Dr. Raktasev, who is from the blood bank. Can I have Dr. Raktasev? So now I am introducing Dr. Raktasev, who is from the blood bank. And now after that scene, he plans to do a patient blood management related meeting with the anesthetist, with the surgeons, and with the nursing officers. So Dr. Raktasev is here. He is from the transfusion medicine department. Please give him a big round of applause. And now, can I request the other doctors to join him? So if you remember from morning, the surgeon, Dr. G. Scalpel, and the anesthetist, Dr. Keto. We also have our nurse, Miss Casual. Please don't mind the name. But you'll understand why I'm calling her Miss Casual. And then there's one more person behind. Haath khada karo. So please guess who he is and what he is doing. What is he up to? मुझे तो समझ नहीं आया अभी तक. So now let's see what Dr. Raktasev has to do and say.
Team, I would like to implement patient blood management for the case of Mr. Asahai. He got anemia and he's planned for elective hip replacement.
But Dr. Raktasev, patient blood management का क्या फायदा? We have been managing fine without it.
Agreed, but बहुत सारे papers publish हुए हैं जिससे हमें पता चलता है कि patient blood management effective है. It can reduce the transfusion reaction and mortality in the patients as well as ये cost effective भी है.
PBM का impact nursing practices पे तो नहीं पड़ेगा ना sir?
Definitely पड़ेगा. इसके लिए आपको patient की hemoglobin की close monitoring करनी पड़ेगी. साथ में अगर excessive blood loss हो रहा है तो you can use tranexamic acid.
But as you said कि ये पेशेंट ब्लड मैनेजमेंट ये बस पेपर में तो नहीं है ना, इसको प्रैक्टिकली कैसे करोगे?
We can make a proper SOP for it and इसमें हम नर्सेज और डॉक्टर्स का हेल्प ले सकते हैं और साथ ही हम रेगुलर ऑडिट भी करते रहेंगे ताकि चीज़ें प्रॉपरली वर्क कर रही है उसका फॉलो अप भी ले सकें.
Beginning to see the value. लेकिन implementation patient blood management का करेगा कौन?
We will make a proper patient blood management team जिसमें हम रेगुलरली रिव्यू और डेटा एनालिसिस एंड ट्रेनिंग करते रहेंगे.
पर ट्रेनिंग कैसे करेंगे सबकी? सबका काम भी बहुत बढ़ जाएगा. काफ़ी लोगों से तो हमें रेजिस्टेंस भी मिलेगा. लेकिन स्टार्ट करते हैं. We'll start with hands-on sessions and workshops. Basic patient blood management का प्रिंसिपल समझना भी तो ज़रूरी है.
Agreed. बट इसके पहले होल ब्लड ट्रांसफ्यूजन का भी कॉन्सेप्ट आया था. फिर हमने ब्लड कंपोनेंट ट्रांसफ्यूजन भी स्टार्ट किया था जिसमें काफ़ी रेजिस्टेंस आई थी. उसी तरीके से हमें पेशेंट ब्लड मैनेजमेंट इंप्लीमेंट करने में भी काफ़ी रेजिस्टेंस आने वाली है.
एग्जैक्टली. टाइम टू टाइम हम आपको इम्प्लीमेंटेशन का प्रोग्रेस भी बताते रहेंगे. लेकिन पेशेंट्स को कैसे एजुकेट करेंगे?
पेशेंट को हम सर्जरी से पहले लिफलेट्स, फ्रीक्वेंटली आस्क्ड क्वेश्चंस, ब्लड ट्रांसफ्यूजन के बारे में इंफॉर्मेशंस ये सब दे सकते हैं जिनसे उनका भी नॉलेज बढ़ेगा.
सही है, बट इसके लिए हमें एनेस्थीसिया और क्लिनिशियंस का रेगुलर कोलैबोरेशन चाहिए होगा.
वो देखिए क्लिनिशियंस और इन सब की तरफ से तो हमको थोड़ा रेजिस्टेंस आएगा ही, एडमिनिस्ट्रेशन में भी कल्चर चेंज करने में टाइम लगेगा, लेकिन रिजल्ट्स और ट्रेनिंग से हम सबका माइंडसेट चेंज कर सकते हैं।
क्लिनिशियन का तो रेजिस्टेंस आना ही है, साथ में हॉस्पिटल एडमिन का भी रेजिस्टेंस आएगा।
और एक आइडिया आया, हम अपने कोलीग्स के बीच में से पेशेंट ब्लड मैनेजमेंट सुपरस्टार्स भी चुन सकते हैं, जिनसे बाकी लोगों को भी काफ़ी मोटिवेशन मिलेगा।
ट्रू, सबके कंबाइंड एफर्ट्स से अडॉप्शन और भी अच्छे हो जाते हैं।
So as you all saw that this was a case discussion meeting where the transfusion specialist was trying to convince the clinicians, and the end was that everybody was, making plans with him. However, they did discuss the obstacles, because that is something which is very, very expected. So they enumerated some of the obstacles, like getting the confidence of the clinician, which I hope you all agree is the foremost problem, that the blood bankers think that, people will think it's just new things that transfusion people keep on saying. So getting their confidence, and then also what they enumerated was getting support of the management. It is so difficult. So which is what they said, getting, आपने clinicians को भी अगर convince कर लिया, but then getting management support. And morning में you would have noticed in one of the session, Dr. Ajay Gandhi, he said that, in some countries it is a national mandate. And then country का institute का भी हो सकता है mandate. It is difficult. So these were some of the obstacles that were pointed out in this session. इसके अलावा what they discussed was training issues. People are not trained. अभी हमारे blood, even transfusion people are not trained. So you're having to train the nurses, having to train your own colleagues. It is not so easy, training your own colleagues. Telling people that what you're doing, you need to do it a little bit differently. So even that is a thing that came up in this session. So all these obstacles and some tentative solutions were discussed in that. And then what happened? So some things were done and some meetings were undertaken by Dr. Raktasev, because he wanted to implement. So the team will now show you some of the things that they did. So here you can see a meeting. The medical superintendent is there and a faculty member is discussing.
गुड मॉर्निंग सर।
गुड मॉर्निंग
सर, ये देखिए हमने हमारे डिपार्टमेंट में पेशेंट ब्लड मैनेजमेंट जो है इम्प्लीमेंट किया था और उसके काफ़ी सेटिस्फैक्ट्री रिजल्ट आए हैं।
आप इसको ऐसे ही कंटिन्यू करते रहिए।
हमें मैनेजमेंट की तरफ से थोड़ी और हेल्प चाहिएगी, जैसे कॉस्ट में और स्टाफ में, इन सब चीज़ों में हेल्प चाहिएगी मैनेजमेंट से।
बिल्कुल, आपको जिस किसी भी चीज़ की ज़रूरत है, जैसे स्टाफ से लेकर या हमारे इंस्ट्रूमेंट से लेकर, जो भी आपको चाहिए होगा, मैनेजमेंट आपकी पूरी सहायता करेगा।
ठीक है, थैंक यू वेरी मच सर। ये पेशेंट ब्लड मैनेजमेंट सक्सेसफुल रहा।
CME symposium workshop.
So these were some of the other things that after that meeting they implemented in the hospital.
Award.
Somebody also suggested that awards can be given.
Hello, I'm Shi, faculty of Obs Gynae, and I practice patient blood management in my department, and results were really great, and I got an award for it. Thank you so much.
So faculty feel good if you give them small awards. So this is something which these people wanted to highlight, that there are some very easy things to do. You can easily conduct regular, but you'll have to, invest your time, your energy, and very creatively address this without a hint of saying that, we are teaching you or something. We can have meetings, we can discuss with them, brainstorming, ask them, all that can be done. So all these things were done by Dr. Raktasev. Now, 2 months later, so Dr. Raktasev called another meeting.
Okay team, time to implement patient blood management. कौन-कौन है on board?
मैं तो महीने से पेशेंट ब्लड मैनेजमेंट को प्रैक्टिस कर रहा हूँ। One man ninja army.
Hold on, Dr. Tito. This patient blood management thing even legit, or it's just a new fad?
नहीं, patient blood management is the game changer. ये blood transfusion medicine का future है।
और सोचो, हम कितना ब्लड भी बचा पाएंगे। We will be the blood saving avengers.
come on, Dr. Scalpel, we will give you right algorithm. And इसमें काफ़ी obstacles आने वाले हैं.
हाँ, I understand. Maybe clinicians are resisting, like good old practices. But ठीक है, हमारे continuous effort से वो भी समझ जाएंगे.
We will show them the right data. और वो खुद बोलेंगे कि patient blood management तो होना ही चाहिए.
So now there is another patient. So another few months later, so there is a surgery which has happened, the same surgery as that first case of Mr. Asahai. वो तो चले गए हैं घर, but now there's the same surgery, same scenario. He is also anemic. There is the same surgeon, the same anesthetist. So now let us see what is happening. Saksham ji को लाया जाए. The difference is that this is a post-operative scenario. This patient was also pretty apprehensive for blood transfusions.
गुड मॉर्निंग मिस्टर सक्षम. आपकी कल सर्जरी बहुत अच्छी रही. अभी आप बेटर फील कर रहे हैं?
हाँ मैम, अभी ठीक है.
मिस्टर सक्षम था. उस समय हमें लगा कि आपको ब्लड ट्रांसफ्यूज करना पड़ेगा, लेकिन हमने कुछ ऐसे प्रैक्टिसेस किए जिससे आपको ब्लड नहीं चढ़ाया गया सर्जरी के दौरान.
अच्छा जी.
आपका हीमोग्लोबिन चेक करके आपको आयरन सप्लीमेंट दिए थे ताकि सर्जरी से पहले आपका हीमोग्लोबिन ऑप्टिमाइज हो जाए.
अच्छा, मन तो बहुत डर लग रहा था, मगर पता नहीं कितना ब्लड चढ़ाओगे मेरे को.
मैंने सर्जरी के दौरान कंट्रोल्ड हाइपोटेंशन और डॉक्टर साहब ने तो पेडिकुलर सर्जरी भी किया, जिसकी वजह से आपको ब्लड की जरूरत ही नहीं पड़ी.
अच्छा, ये तो बहुत अच्छी चीज़ है जो आपने मेरा ब्लड मेरे को ही चढ़ाया. मैं तो सर कल छुट्टी करा के यहाँ से जब अपने गाँव जाऊँगा तो ये जो मेडिकल एजुकेशन है इसको वहाँ पर जाकर कंटिन्यू करूँगा. अपने गांव में सभी को बताऊँगा कि आपने इतनी अच्छी टेक्निक यहाँ पर जो उपलब्ध कराई है, इसके लिए बहुत बहुत धन्यवाद. राम राम जी.
So the patient is happy now this time because he didn't have to be transfused and he seemed happy also. वो पहले वाले मरीज थोड़ा दुखी दिख भी रहे थे, ये वाले मरीज खुश हैं, खुशी खुशी गए हैं because his anemia is also balanced now. इनको आदत पड़ गई थी उस anemia में रहने की, but अभी now this patient is no more anemic. So I asked you all to notice that young fellow जो इधर उधर झांक रहे थे. I hope some of you noticed. कौन थे वो? Who was he? He was an intern. So let us see what that intern is up to now. So Dr. Raktasev के पास वो आए हैं. This is another 2 months later and it seems like it is his blood bank posting.
गुड मॉर्निंग सर.
गुड मॉर्निंग
सर, आज से मेरी ब्लड बैंक में ड्यूटी 2 वीक्स की पोस्टिंग जो है वो शुरू हो रही है.
तो फिर एक्साइटेड हो पोस्टिंग को लेके?
हाँ सर, मैं बहुत एक्साइटेड हूँ मेरी पोस्टिंग्स को लेके.
तो इसके पहले कहाँ पोस्टिंग थी तुम्हारी?
सर, इससे पहले मेरी पोस्टिंग सर्जरी डिपार्टमेंट और उससे पहले एनेस्थीसिया डिपार्टमेंट में थी.
तो तुमने वहाँ क्या देखा?
मैंने देखा सर कि आप अपने कोलीग्स सर्जरी और एनेस्थीसिया कोलीग्स के साथ आप डिस्कस कर रहे थे एक केस के बारे में जिसका मेजर ऑपरेशन होना था, लेकिन उसमें पेशेंट ब्लड मैनेजमेंट इम्प्लीमेंट करके आप लोगों ने उसे बिना ब्लड ट्रांसफ्यूज किए एक मेजर ऑपरेशन को ईजिली हैंडल कर लिया विद द यूज ऑफ न्यू टेक्निक्स लाइक हीमोडाइल्यूशन एंड ऑटोलोगस डोनेशन की मदद से.
तो तुमसे क्या सीख लेते हो?
I learned from this case that I took vows to implement patient blood management throughout my life, and I also encourage my colleagues to implement patient blood management throughout the life, and I will not transfuse a single unit of blood without any proper indication because every blood drop matters.
Good.
Thank you, sir.
So apart from being fun, the role play in the first meeting, you all saw some obstacles which everybody pointed out. So we all agree with those obstacles, and there are some more also. And then in the second meeting, they suggested ways how to overcome and how they have overcome some of them. And as I've been also noting down since morning, some of those things were also here. For example, they said we will review some data, we will look at evidence-based management. So some of the trials have been mentioned in the morning by Dr. Satyam. He talked about the ETNO trial. All these things, there are solutions to everything, which is what I mean to say. And then Dr. Gandhi also gave us a very detailed thing when he said that things have to be patient-centric. So I hope you all have noticed here, the stress was on patient centricity, rather than doctor centricity. उनके OT schedule के हिसाब से नहीं. It is based on of course, the doctors understand the patient's needs, but they also listen to what the patient wants. It's his body. Whether he wants a transfusion, if he wants less transfusion, PBM helps. So some of these things were also referred to in this role play, and I think the residents have very successfully pointed out those things, and I was actually pretty apprehensive that instead of taking a lecture, a PPT thing, I am handing it over to the residents. Will all the points come out? But I think they've done a pretty good job. And the reason for having the intern, उसका एक लास्ट में एक्स्ट्रा सीन भी ऐड किया गया. So my aim here was that everybody has to understand that these young minds have to be influenced. जो senior हो गए, they have to work on these young minds. So this intern is going out with the thing. Now whether he joins transfusion or pathology or microbiology or whatever branch he joins, he may become a CTVS surgeon, he may become a neurosurgeon, a hemato-oncologist. He at least has something in his mind कि ऐसा कुछ मैंने देखा था. He may or may not remember it fully, but he will have those things, and he will here or there कहीं ना कहीं उसके दिमाग में रहेगा कि I have seen these things and I should implement them. So here this was an exaggeration. He said, I'm taking a vow, all that. So we are exaggerating everything, but then the point is that using such things, we talk about training your doctors. So you can use this kind of small, silly, maybe sometimes role plays and all. So the message reaches the heart. खाली PPT से message नहीं जाता. So if you want soul in your trainings, try to go for some of these techniques. Just wanted to demonstrate कि कोई भी चीज़ का message if you have to pass on, so it can be done with things like this. PPTs are just to help us, but so I hope the message got regarding obstacles and potential solutions. Thank you.
Thank you, ma'am, for such a thought-provoking session. Now I would like to invite Dr. Manish Raturi, sir, to kindly felicitate Professor Geeta Negi, ma'am. Further, I would like to invite Dr. Daljit Kaur, ma'am, to felicitate Dr. Manish Raturi, sir.
Dr. Ratsasev, आ जाइए. Thank you. All the actors, please come. Dr. Ashish, Assistant Director, आ जाइए. He was the Assistant Director for this role.
Thank you, ma'am. We now begin an exciting panel discussion titled Blue Sky Thinking, Establishing Patient Blood Management Strategies in a Multidisciplinary Approach, where our expert will share the futuristic strategies for implementing patient blood management in a multidisciplinary hospital setting. To moderate the session, I would like to invite Dr. Daljit Kaur, ma'am, Associate Professor, Department of Transfusion Medicine, AIIMS Rishikesh. Ma'am is an Associate Professor of Transfusion Medicine in AIIMS Rishikesh. Ma'am has done MBBS from Government Medical College and Hospital, Chandigarh, MD Transfusion Medicine, PGI MER, Chandigarh, Fellowship in Medical Education, FEMA 2020, Achievements include member of ISTM, special interest group for patient blood management, NABH assessor for NABH blood bank accreditation program, Harold Gunson Fellowship for MD Transfusion Medicine, thesis student 2024, awarded for paper presentation at AIIM Muscat 2024, Science and Engineering Board International Travel Grant 2019, publication in national and international journals, membership of professionals.
Thank you so much, Priyanka. So, good afternoon all. After a stunning high energy session, let's move on enthusiastically to the finale panel discussion. How is the Josh? Intact? Chalo, happy to see you all. So, one of the most enticing concepts behind PBM is that it is one of the few areas in medicine where risk can be reduced, outcomes can be improved, and money can be, saved. We have been hearing this since morning that we can save a lot of money. So, and all this is happening at the same time. So, it's natural that we discuss it and implement it, in the best possible way. So, through this session, that's blue sky thinking, establishing a PBM strategy in a hospital setting, let's get going towards developing a successful program in a hospital setting through a panel of multidisciplinary experts. I would like to humbly invite and introduce our experts for this session, and I would request them to, all of them to take position on dais. First, I invite Professor Meenu Bajpai, ma'am. Can I have the CV? Dr. Priyanka, can I have the CV? Professor Meenu Bajpai, ma'am. She is heading the Department of Transfusion Medicine at ILBS, New Delhi. She's a chairperson of SIG group on therapeutic apheresis by ISTM. She's member for National Policy on Hemoglobinopathy. She's faculty in charge for PDCC courses at ILBS for apheresis technology, immunohematology and blood banking, and transplant immunology. Her areas of interest and passion are apheresis and immunohematology. We welcome you, ma'am. So next I invite Professor Uttam Kumar Nath. He is professor and head of medical oncology hematology, AIIMS Rishikesh. He's MD internal medicine and DM clinical hematology, and he has vast experience of 16 years in teaching DM course. So big round of applause. We have great teacher with us. Principal investigator of 4 extramural research grants, 15 years of experience as PI and co-PI of phase 1, 2, 3, 4 global multi-centric clinical trials. So, and fellowship of Indo-American Cancer Association and International CML Foundation. His mentor, Ramalingam Swami Fellowship, DBT, Government of India. His member, Subject Expert Committee, CDSCO and DCGI. We welcome you, sir. Next, I invite Dr. Lalit Dhantole. Dr. Lalit, he is MD Transfusion from SGPGI Lucknow. He is now consultant and head transfusion medicine, Fortis Hospitals, Mulund, Mumbai. And his achievements include implementation of therapeutic apheresis and stem cell cryopreservation program at Fortis Hospital. He has performed more than 250 procedures with the span of 2 years, including cascade filtration. And he has received PG Fellowship Award in 2012 by ISTM. He's an active member of Federation of Bombay Blood Banks. He's a certified cellular therapy specialist by AABB and George Washington University. Thank you. We welcome Dr. Lalit. Thank you for coming over all the way from Mumbai. And next, I invite Dr. Anish Gupta, who is Associate Professor, CTVS at AIIMS Rishikesh. He has done his MCH from AIIMS. His achievements include, he has pioneered pediatric cardiac surgery and aortic surgery program at AIIMS Rishikesh. He has performed over 300 congenital heart surgeries, and he has over 50 index national and international publications. He has been delivering a lot of lectures, and we often see him delivering lectures and trainings through social media as well. He is really a tech-savvy person. So we welcome you, Dr. Anish. Next, I invite Mr. Elvin. So Mr. Elvin, he is working with us at AIIMS Rishikesh. He is a nursing officer, registered nurse, and he has over 13 years of experience in critical care units. And he has worked in hospitals who has accreditation, JCI, NABH, and NAC accredited hospitals. He is currently working as ward in charge CCU at AIIMS Rishikesh, and he has also worked as quality nurse and infection control nurse. He is certified with ATCN and ACLS, and his achievements include, he has achieved Best Nursing Officer Award at institute level at AIIMS Rishikesh, and he has research publication as well. We are privileged to have you, Mr. Elvin. Welcome. So since morning, we have heard that PBM is the quality practice of medicine with regard to preventing and managing anemia and optimizing coagulation to prevent or reduce bleeding, promoting optimal blood conservation and achieving all of these goals with an evidence-based patient-centered focus in order to improve outcome. Now let's dive deeper into several other essential aspects related to this which we might not have covered earlier, and let's deliberate on those aspects for PBM program. So we have 5 speakers and we'll stick to time. We don't you all to waiting for Ganga Aarti. We know we have a lot of people coming over from all over India. So myself and my panelist, we will try our best. So maybe we can 6 minutes per speaker. So first of all, I'll ask Meenu ma'am. Ma'am, we know that you have vast experience at ILBS, I think over 1.5 decade. So I would like to know how does point of care testing influence the PBM program? And since seeing your experience, what PBM strategies are being applied at your centers while they are performing liver surgeries? Please, could you enlighten us?
Come to this. For liver, I just want to give a small background. I have a hematology expert beside me. That a liver disease patient is a patient with rebalanced hemostasis. So over here, what happens, he has very low levels of coagulation factors, procoagulant factors as well as anticoagulant factors. The balance is very fragile. And whenever you're transfusing this patient, you tilt that balance. So he may either go into hemorrhage or he may go into a thrombosis. So it's very important not to transfuse unless required in this patient category. The other thing is the laboratory tests will not always, the routine laboratory tests will not reflect the patient's true hemostasis position. That can only be taken by 2 ways. Either the patient is bleeding and you're giving a therapeutic support in terms of blood components. And the second is point of care testing. So the point of care testing is very critical in these patients, and we have been having it since 2014. We have been having initially TAG and then Zotam. Rotam is even better than TAG. You have FibTem and XTem. So pre-op, intra-op and post-op, all the support we give is based on the Rotam, the point of care test which is there in the liver transplant OT side. It is available over there, and it improves the outcomes vastly. When we started the program and we were doing it, and it was not so well thought out, we were preparing around 20 units of RBCs, 20 FFP, 20 cryo, and 4 units of single dose and apheresis. And now over 1.5 decades, now we are using point of care test, and we constantly follow the patient, and we are giving patients based on point of care testing. And now our preparation for the surgery has decreased drastically. From what we started with. Now we only prepare 10 units maybe of RBCs, and we have the rest of the components in place, and not much, maybe 1 or 2 SDA, single donor apheresis platelets. That's all we prepare these days. Now another point I want to point out, that if fibrinogen is affordable to the patient given, and there is a very important reason for this in liver disease patients. The reason being that von Willebrand's factor and factor 8 are acute phase reactants. They are already high in the recipient. because of liver disease and because of all the inflammation, they are high. So when you're giving the patient fibrinogen in the terms of cryoprecipitate, you're also adding more von Willebrand's factor and factor 8 in the patient who already has a large amount of that. So that's problematic in these patients. So one of the things is give fibrinogen. Another is whenever we transfuse the FFP to these patients, FFP has a large volume and it is going to a single unit may only raise the percentage of coagulation factors by 1 to 2%. So over here you are very likely, if you're able to correct the coagulation factors, the patient will go into volume overload. And there will also be an increased risk of bleeding. Because of the increased portal pressure, portal hypertension, there's an increased risk of bleeding. So in these are ideal patients to give the current day PCC, which also has protein C and protein S, to decrease the risk of this and to give fibrinogen. So wherever cost is not a constraint, it is better to give PCC and fibrinogen rather than giving the cryoprecipitate and FFP, which lead to volume overload And so most of the GI bleeds, we don't transfuse we don't correct coagulation, we try to correct the bleeding spot, try to treat the bleeding in surgical methods in these patients. So there's a lot of things which have to be kept in mind when we are talking about what you call a patient blood management in the liver disease setting and in the transplant setting in these patients.
That's amazing, ma'am. So rightly put. And since our institute is also heading towards, liver transplantation in future, so I would request Geeta ma'am also, and we can discuss that we should start in the right way only. So your experiences are like amazing, they're marvelous. So we should, rather than focusing on 6 SDAPs and 4 SDAPs, we should be switching over to PBM and utilize 1 SDP, and we should advocate PCCs and, fibrogen concentrate as well. So thank you, ma'am. You have very well addressed the points where clinicians can avoid arbitrary administration of blood components and can rely on point-of-care testing for timely diagnosis of anemia, bleeding, and coagulopathy. And point-of-care coagulation testing is most desirable in emergency and surgical settings where clinical diagnosis and interventions are time-sensitive. That's true. Thank you, ma'am. So let's move on to our next panelist, Professor Uttam, sir. Sir, I would ask you to, elaborate on the PBM strategies that can be employed for managing your subset of population, that is hematology patients, for management of anemia as well as thrombocytopenia.
There are two aspects. Like one is a patient who has a hematological malignancy or bone marrow transplant setting, and the other group of patients is any anemia patient with anemia walking to your OPD or being admitted with severe anemia. Now, if the diagnosis is known, it's possibly a nutritional anemia or you're suspecting nutritional anemia, then even at very low hemoglobin, your patient tolerates the anemia. Why? Because the hemoglobin has dropped maybe from 10, 11 to levels of 4 gram or 3 gram per DL over a period of time. So it is better tolerated by the patient, but it has hemodilution. So in this patient, if you are suspecting a nutritional anemia, then we should focus on correcting the nutritional deficiency rather than transfusing. But saying that if the patient has any cardiac comorbidity, or if the patient is in gross failure, or if the patient is symptomatic, like it is interfering with the activities of daily living, then very cautious transfusion strategy with packed red blood cells, maybe 1 unit or 2 unit, and not more than 1 unit in a day, with supervision to avoid volume overload, maybe with some amount of diuretics, maybe indicated and necessary initially. So it depends on the symptomatology of the patient. But often young patients with hemoglobin of 3, even lower, we prefer not to transfuse. So depends on your patient's comorbidities, the age, how much the severity of anemia is affected. And if the anemia is of acute duration, like hemoglobin has dropped from say 13 to 8 or even 9 rapidly in 2 weeks, 3 weeks, the patient becomes symptomatic even at hemoglobin of 8. So there you need to know the causes, like whether it's acute hemolysis, whether it's acute blood loss. There, if the patient has cardiovascular disease or ischemic heart disease, even you have to target a hemoglobin close to 9. In the critical care, in the CCU or ICU patients, we prefer a restrictive transfusion strategy, hemoglobin of 7 maybe. But again, if the patient has severe thrombocytopenia, say a patient with platelet count of 10,000, 15,000, the hematocrit has to be targeted close to 30. So you have to transfuse RBCs so that at the low platelet count level, your patient's risk of bleeding decreases. We all know the mechanism of increased risk of bleeding at low hematocrit because the platelets do not tend to interact with the endothelium. Regarding thrombocytopenia, again, whether it's a prophylactic platelet transfusion or therapeutic platelet transfusion. Therapeutic means patient is having bleeding. You have to control the bleeding. And prophylactic means you don't want your patient to bleed. Suppose a patient on chemotherapy or a critical care unit patients with sepsis, you have to see whether the patient is having bleeding or not. If there is bleeding, even at platelet count of 20-25,000, if there is coagulopathy like DIC, you may have to transfuse because there you have to control the bleeding urgently. But if there is no bleeding and patient is stable, not in sepsis, not febrile, there you can target a platelet count of 10,000. So if platelet count is less than 10,000, you transfuse.
So,
Okay,
so
because
you
that is
mean
the
so we
critical.
should not stick to absolute thresholds of platelet count? You were saying it's
No.
based on.
See, suppose a patient of aplastic anemia, his platelet count always remains low. They are being managed in the
Yeah.
OPD, so you don't need to transfuse. But 10,000 is the critical point because often they are having anemia.
Yeah.
They are having repeated infections. So if you don't want your patient to bleed and come with a critical bleeding, you may have to transfer.
So
For leukemia patients, for
yeah.
critical care patients, 10,000
Yeah.
if the patient is stable. But sometimes the patient is having infection.
True. So
Fever.
we also wanted to know that for such patients, other than apart from blood components, what other maybe pharmacological measures, what other
for
measures,
thrombocytopenic bleeding,
or for anemia,
for
what?
thrombocytopenic bleeding, there is no substitute for platelets. You can use adjunctive therapies like tranexamic acid or EACA, the antifibrinolytics. But if the platelet count is very low, your patient is having fever. So fever and infection increases the consumption significantly.
True.
So even at platelet count of 20,000, there is risk of bleeding. You don't want the patient to have an critical bleed. Minor bleeding is okay. So tranexamic acid or EACA.
True.
Then again, I told you about the correction of anemia. You increase the hematocrit to close to 30. If the patient is having lab parameters of DIC, you may have to target the platelet higher, 30,000. But in other settings, like even in the CCU or in the general wards, if the platelet count is say 10, 15,000, look for the cause. You have to do the workup urgently.
Thank you.
And another adjunctive policy and strategy is to avoid drugs which increase the platelet consumption, like amphotericin B, vancomycin.
Absolutely, sir. So you have touched the same theme which we were discussing in the morning. We have to look into the root cause first and then, start asking about blood components. It is as simple as that. And sir, you have...
About ITP. Often we have patients platelet count 1,000, 2,000. So whether to transfuse platelets or not. Earlier we were told don't transfuse.
Absolutely.
Now the thing is, even the guidelines mention if there is presence of major bleeding, then along with the ITP directed therapy like intravenous immunoglobulin, steroids or rituximab, you have to transfuse platelets just to tide over the crisis. If a lady is having severe menorrhagia, if a patient is having GI bleed, then if a patient is hypertensive and with bleeding, with say retinal bleeding, you may have to transfuse initially till the time your drugs work. Because it's not all patients are not the same.
True.
So higher age, hypertension, these are risk factors for bleeding.
And so since you mentioned that...
Add one thing over here, when you are transfusing in these conditions, don't monitor the platelet count.
Yeah.
Hemostasis is going to happen, but the
Yeah.
platelet count won't rise.
True.
So you're just supporting the hemostasis.
True.
The platelets are going to get consumed at a very high
True,
speed.
true.
So you can't monitor by platelet count.
Yeah.
And bleeding is a vicious cycle. Bleeding causes anemia.
Anemia,
It
that's what.
tends, patient tends to bleed more, and the patient is at risk of critical bleed.
Yeah.
Target is to prevent critical bleed,
Critical
like
bleed.
intracranial bleed.
Rather than looking for 4, 6, 8 units of components, we have to target that. We have to prevent bleeding, we have to treat anemia. So thank you so much, Uttam sir, for enlightening the hall about this pertinent topic and how well we can plan our care for the oncology patients using PBM strategies. Thank you very much. So moving on to our next panelist, Dr. Lalit. So I would like to ask you, how does preoperative optimization of coagulation function aid in PBM implementation? And do you consider topical hemostatics and fibrin sealants a good adjunct in PBM implementation in surgical patients?
So good evening all. So the first question is basic. For all routine surgeries, apart from the liver surgeries, the routine investigations, that is coagulation factors, PTA, PTT, INR, then fibrinogen levels, the platelet counts, will basically be, we can actually predict whether the patient will be bleeding or not. There are basic set targets for each and every surgery. Say for example, neurosurgeries, the target will be on a higher side, but for all routine surgeries, the platelet counts, the coagulation factors will be all fine. What we need to see that pre-operatively, if we manage all these coagulation factors and platelet counts, it is the intraoperative management, the loss will be on a lower side. So we are actually targeting the second pillar of the patient blood management.
Yes,
great. And suppose even if we have any sort of coagulation defects or platelet abnormalities, pre-operatively, we can actually manage it with biomedications. Say for example, most of the coagulation factors like vitamin K, supplementation can be given, desmopressin can be given for platelet increment. So these will actually increase the coagulation system, stabilize the coagulation system, and it will help in intraoperative management. The second question is
topical hemostatics or fibrin sealants.
So the topical, the fibrin glue, it's basically a combination of thrombin and fibrin. So it's derived from human source. So that reactions which are associated with blood transfusion will be on a similar side. But what the thing is, can be used for to control localized hemostasis. It can achieve localized hemostasis, not for arterial bleed or a prompt venous bleed, but localized capillary, and it can also be used in an areas which has difficult to access site. So and it has been observed that these are as potent as the other surgical techniques like compression or Surgicel, even these kind of therapies. The fibrin glue is quite stable and can be used in these kind of scenarios.
True, true. Thank you so much. Thank you so much. Thanks, Dr. Lalit. So aptly stated how topical hemostatic agents are used when surgical hemostasis is inadequate or impractical. For example, different areas as peritoneal or pleural bleeds or cut surfaces of solid organs, bones, bleeding near vital structures or nerves where your cautery might result in injury to such structures. So in those areas, which are, quite a good number of cases, there we can use this topical hemostasis. So Cochrane database review performed a meta-analysis of 7 quality trials of fibrin sealants, where this fibrin sealant was used to minimize perioperative bleed, perioperative blood transfusion, and they found a reduced rate of exposure to allogenic blood transfusion by 54%, which was coinciding with average reduced blood loss of 134 ml per patient. So that is quite significant, massive. So that means, undoubtedly this is a PBM strategy. So thank you, Dr. Lalit. So moving on to Dr. Anish, who is a CTVA surgeon. I would like to ask what special perioperative measure you consider while performing your routine cardiac, which can actually help in avoiding allogenic blood transfusion, perioperatively.
Good evening, everyone. Ma'am, actually, we follow a multidisciplinary approach for patient blood management during our cardiac surgeries. So it starts right from the pre-admission phase. We take a history for any bleeding tendency, the drug therapy. Many of our patients suffering from coronary artery disease are on aspirin or ticagrelor or prazogel, these kind of drugs. And we look for any coagulopathy, and we have various scoring systems like will bleed score, or maybe should not bleed score for CABGs, and there are many other ones. If the patient is in atrial fibrillation, VAL patients, rheumatic heart disease, they will be on acetrom or other NOACs. So we optimize right from there. We have aspirin. These days we continue aspirin during surgery. We don't stop it. But clopidogrel will stop 5 days before surgery unless it is an emergency. And then we should optimize anemia, as already pointed out by in the morning. So then during surgery, we have a lot of different measures, which from anesthesia side and perfusionist side. Like from anesthesia side, sometimes we take autologous blood from the patient and we transfuse it after the surgery. From perfusionist side, there are things like ANVH. ANVH stands for acute normovolemic hemodilution. So basically they will take some blood from the patient before the operation and will maintain the normovolemia by giving some crystalloids, and will bring down the hemoglobin. Then during perfusion, when the patient is on a heart-lung machine, ultrafiltration. So there are basically 3 types of ultrafiltration. One is conventional ultrafiltration, which is like hemodialysis, sort of. And then we have zero balance ultrafiltration, where we do not make the patient negative. And but these things, they remove the inflammatory mediators, and all these things help in decreasing post-operative bleeding. And they bring up hemoglobin also. Then we have modified ultrafiltration. MUF is done once the cardiopulmonary bypass is weaned off. So that is by the aortic pressure. And we will remove some water and bring up the hemoglobin. And we have a study going on, MUF in adult patients, and it already has proven benefits in neonates and infants. Then we do something called as priming, autologous priming. So there are 2 kinds of autologous priming. One is antegrade, one is retrograde. So if the patient hemoglobin is good, maybe 13, 14, then once we do aortic cannulation, we put a cannula in the aorta and we attach it to a heart-lung machine. Then the perfusionist will take some blood back from the aorta into the heart-lung machine, and he has added some priming volume in the circuit, which will be like crystalloid. Maybe sometimes we add FFP also into it. So when he takes the patient's own blood into the tubing, the water in the tubing he will take out. There are different ways to do that. So that is a retrograde autologous priming. And then he can also do antegrade autologous priming. There is another line in the venous system, SVC, IVC, or maybe in a right atrium. So we'll take blood from there and we'll take out water from some other place. So by these things we can remove the dilution that is happening by the heart-lung machine, and the hemoglobin will be optimized and will prevent the post-operative allogenic blood transfusion. But we need good hemoglobin for this, and the hemodynamics should be okay. Patient's BP should be fine while we do all these things. Then there are other things in the post-operative period. We can use cell saver. Cell saver, I think cell saver is a very good device. We already Aarti gave a presentation on it. We used in non-cardiac surgeries also. And by using cell saver, we can, there are many, Cochrane review there, around 40 RCTs, which has shown that it decreases the allogenic blood transfusion.
So, on an average, how many ABTs, how many PRBCs maybe you have avoided per patient, when you are performing, utilizing these strategies? So can you share your experience? So supposedly you were asking 6 or 8 units per patient. So how many have you actually reduced?
If the perfusionist, it also depends on the perfusionist. If the pump is run in a good way and the hemostasis is good, then many times routine cases like ASD closure, mitral valve replacements, even CABGs, we have done without transfusion also.
Yeah, that's really amazing. So kudos. Yeah, sure. So happy to see that most of the PBM strategies are already there with cardiac surgeries.
Usually in the fall, even up to 20%. So what is your baseline platelet count where you are comfortable doing cardiac surgery? We sometimes get referrals, the platelet count is 80,000, 90,000, patient is planned for some cardiac surgery. Because particularly for cardiac surgery, because of the pump, platelet count falls within 24 hours.
If it is not an emergency surgery, elective surgery, 1.5 lakhs we would try. If it is an emergency surgery, then at least 50,000. 50,000 for any 50,000 for emergency surgery and 1.5 lakhs for elective.
bypass pump जब आप यूज कर रहे हैं उसमें ही तो ज़्यादा प्लेटलेट कम होता है ना.
But if sometimes there are emergency surgeries, like patient is in heart failure, needs an urgent mitral valve replacement. So if the platelets are more than 50,000, we have done surgery and we can anyway replace them. Transfusion requirement will be high, but we have to do these emergency cases. I have refused patients with less than 50,000, but 50,000 above I am okay to go. Elective 1.5 lakhs.
No, but suppose if there's around 1 lakh and it is an elective surgery, so you'll.
I can. I will take a hematology opinion. Why it is 1 lakh? There must be some reason.
Because see,
So you see-
even for neurosurgery it's 1 lakh. Even for neurosurgery it's 1 lakh. So.
Sir,
It is
our
1.5
CTVA surgeon, Dr. Anish, is motivated like Dr. Rohan, who was an intern. He is AIIMS Rishikesh student, so he's motivated enough that he will operate at lower threshold also.
So depends on the.
Because platelet transfusion, if you ask us our opinion, if you have to do the surgery, platelet count is 80,000, 90,000, transfuse platelets. Okay. That is our and target 1 lakh. That is what.
That was there.
What is the average loss of platelets on using the extracorporeal circulation?
After any surgery done on cardiopulmonary bypass, platelet count would be around 1.2, 1.2.
No, how many thousand, what is the decrease?
Difference.
What is the consumption by the
pre
pump?
and post? Pre and post.
Almost 50%.
50% or, no, it is, I think for just, if it is around 40,000, there can be a dip of up to 40,000 by count. If it's 1.5, it might end up at 1.1.
I see, we send a CBC on day 0 of every patient, and I always see the platelet count something around 1 lakh, 1.2 lakhs after surgery. And before surgery, they are normal only.
Okay.
That could be 1.8 or anything.
Maybe 2
till
lakhs,
4
1.8,
lakhs,
2
maybe.
lakhs,
Yeah,
like
that could be. So thank you so much. That's great indeed. As I said, that happy to see that all the strategies have been already implemented for cardiac surgeries. And I would also like to share that several examples exist that document the benefit of these energetic PBM interventions during cardiac surgeries. Various studies from US report that implementation led to reductions in blood utilization, reduced transfusion-related adverse outcomes that significantly reduced cost, morbidity, and improved patient outcomes. So isn't it what we actually wanted? So we have evidence also. So next, I would like to ask Mr. Elvin. As a nursing representative, could you please share your role in implementation of patient blood management at ward side? And how can we involve patients in the decision-making process for anemia management in the pre-operative period as regards your PBM implementation in your area of posting?
Okay, ma'am. Good evening all, first of all. The NACE are the pillar bone system in the management, because nowadays we are treating the patient as a multidisciplinary management. So in that, the nurse have to help, first of all, the team, like that. First of all, identify the cause. Cause means sometimes the anemia due to lots of administration of the infusions. So we have to maintain the adequate and accurate IO chart properly. Same way, the nurse have to identify the cause. Sometimes after the surgery, there are bleeding spots in the patients. So the nurse have to accurately and promptly identify these spots. So it's also helpful to identify the cause of anemia. Sometimes some drugs also will be reduce the count. So by taking the vitals also. That means some nosocomial infections also lead to reduced counts and also lead to anemia. So by assessing the patient in a proper way and in 24/7 times, we have to identify the cause, and it's easy for the team to identify the cause of the anemia. With the adjuvants or any therapeutic way we can manage, then it's better. Otherwise, we have to transfuse the safe way and effective way, blood transfusion and blood clots. For that, in that time also, they have to maintain the sterility, and also they have to proper sampling techniques and proper infusions, and avoid the contamination of the blood, and they have to maintain the temperature, and same way, they have to preserve the blood also, because sometimes in the practical sections, the requisition form and slips, all the things will be sent to with the patient relative. Then they will be taking the blood samples, and they will be went to tea shop and take a break, and after that they will be come to the departments. Then in that time the potency of the blood is also lost. So we have to educate the patient and team that the importance of the accuracy administration and the time importance also. We have to educate the patient and patient relatives also. So same way we also check whether the patient have any adequate or need is there in the scenario. So we have to check whether the importance. So in that time, we also document the things adequately. Sometimes the patient need only few volume of the blood for the transfusion, but in the PRBC, large of the volume will be received in the ICU sections. So we have to notify whether how much volume is patient needed. So based on that, the blood bank will be issue the adequate volume also. So like that, we have also preserved the blood and blood products also. Same time, in the decision-making time, we have to encourage the patient to take other adjuvants and other supplements for developing the counts. Sometimes in elective surgeries, the empowerment and mental strength itself will develop the blood count in adequate positions. So we have to educate the techniques that we have to use before the surgeries. And same way, in post-operative period, we have to tell the patients regarding the process or the steps which will be involved in the treatment. It's also helpful to improve the blood loss and also improve the blood count level also. So, and take appropriate decision, because most of the patients doesn't know aware regarding the education, what they have to do while reducing the count, what they have to take, how they have to take, what route they have to take, like that. So the main nurse's role is that promptly identify the root cause and inform the team, and with the team they have to make a plan, and based on that the team have to intervene the patient to deliver the proper treatment for the patient to improve the count of the patient.
That's fantastic, Mr. Elvin. So team transfusion, our job is half done already. So Mr. Elvin, very well put. So nurses educate patients about PBM principles, the importance of minimizing blood loss, and the risks and benefits of blood transfusion. They advocate for appropriate blood conservation strategies and ensure that patients understand their treatment options. This patient-centered decision-making forms an integral part of PBM program. So with that, we are happy that we have a lot of PBM-trained officers in our hospital. So this is a good beginning. So summarizing the whole discussion, since the end goal of PBM is to achieve and maintain blood health, where patients receive proper care for their blood like other organs, it is imperative that we integrate it with health promotion or disease prevention model. This highlights the shift of care from eminence-based, that is transfusion and replacement oriented, to evidence-based care, which is PBM methodology and integrating it with unique prevention levels. As Ravneet ma'am had mentioned in the morning, 5 unique levels, primordial and primary to quaternary, which will address the social determinants of health along with all other treatment factors that we discussed since morning. So the inputs which all of the panelists gave, that was on the cake. So we were enjoying our session since morning. Everybody added immensely to all the sessions. Hence, education plays a key role in the development of PBM program, which was well highlighted in the previous session as well. And all of you, our worthy panelists, also added a lot. I thank each and everyone for joining us and for your amazing inputs. Thank you so much.
A big thank you to all our panelists for such a vibrant and meaningful exchange of ideas. Your insights have emphasized the strength of interdepartmental collaboration and achieving the effective blood management. Now I'd like to request Dr. Geeta Negi ma'am, Dr. Daljit ma'am and Dr. Ashish sir to felicitate our panelists. Dr. Webb, would you like to join? Please request you to join us for the felicitation of our guests, please. Dr. Anupam sir, we request you to join to felicitate our guests. First of all, I'd like to request ma'am to felicitate Professor Meenu Bajpai, Transfusion Medicine, ILBS, New Delhi. I'll request ma'am to felicitate Professor Uttam Kumar Nath, Head of Medical Oncology and Hematology, AIIMS Rishikesh. Further, Dr. Lalit Dhantole, Consultant, TM Fortis, Mumbai. Dr. Ashish Gupta, Associate Professor, Critical Care, AIIMS Rishikesh. Mr. Elvin, Nursing Team Representative. Further, I would like to request Professor Meenu Bajpai ma'am to felicitate our moderator, Dr. Daljit Kaur ma'am.
हाँ बिल्कुल मज़ा नहीं आ रहा था. So, good evening to all. Now we are in the valedictory session. Both an honor and privilege to stand before you today as we draw the curtain on what has been a highly enriching and thought-provoking CME program. Over the past one day, we have dived deep into the theme patient blood management, a topic of immense relevance in today's healthcare landscape. We have witnessed expert deliberations, cutting-edge presentations, and meaningful discussion that have enhanced our understanding and challenged our perspective. For this, actually, I have written a poem, so for PBM, and actually in the valedictory, I want to add what is actually from a patient point of view. एक पेशेंट क्या सोचता है PBM के बारे में, तो वो अपनी एक्सपेक्टेशन को एक मैं कविता के माध्यम से आपको बताना चाहूँगा. तो एक पेशेंट कहता है, एक बार कोशिश तो कर लो, एक बार कोशिश तो कर लो, ब्लड के अलावा और कोई रास्ता तो खोज लो. एक बार कोशिश तो कर लो, ब्लड के अलावा और कोई रास्ता तो खोज लो. सोचता है मरीज, सोचता है हर मरीज अपने ऑपरेशन के दौरान, सोचता है हर मरीज अपने ऑपरेशन के दौरान, शायद अपनी जिंदगी के पहले डर के दरमियान, शायद अपनी जिंदगी के पहले डर के दरमियान. कहता है सहमति देता हूं मैं आपके हर निर्णय में, सहमति देता हूं मैं आपके हर निर्णय में, भरोसा रखता हूं आपके हर हुनर में. ब्लड चढ़ना एक व्यक्ति के लिए सामान्य बात नहीं होती, जोखिम के अलावा किसी और के शरीर के अंग को लेने की हिम्मत नहीं होती. जोखिम के अलावा किसी और के शरीर के अंग को लेने की हिम्मत नहीं होती. जानता हूं कि आप मेरे भले के लिए ही ये सब कर रहे होगे, जानता हूं कि आप ये सब मेरे भले के लिए ही कर रहे होगे. ब्लड की कमी से मेरा जीवन ना जाए, बस यही सोच रहे होगे. मुझे पता होता, मुझे पहले पता होता तो मैं अपना खून बढ़ा लेता प्री ऑपरेटिव. ये मौका आए ऐसी नौबत ना आने देता. खैर, अब जो कुछ भी गूगल अंकल ने बताया है, ऑटोलॉगस या ब्लड सैल्वेज हो जाए तो क्या बात है. ऐसा भी नहीं कि मुझे ब्लड चढ़ने से बहुत कुछ बदल जाएगा, पर ये ब्लड किसी ज़रूरतमंद के काम तो आ जाएगा. एम्स ऋषिकेश में आया हूँ तो इलाज तो अच्छा होगा ही, और पीबीएम इम्प्लीमेंटेशन के वैसे नॉन ट्रांसफ्यूज कहलाऊंगा भी, नॉन ट्रांसफ्यूज कहलाऊंगा भी. तो ये सारा समराइज है पीबीएम को जो हमने सीखा है, मरीज ने क्या अपनी एक्सपेक्टेशंस की हैं, और अल्टीमेटली अगर हम प्री ऑप और इंटर ऑप को करते हैं तो वो एक खुशी खुशी जाएगा, जैसे रोल प्ले में बताया गया है. सो अब हमारे यहाँ फ्रॉम द सुबह से जो प्रेजेंटेशंस हुए हैं, दैट मिनी ओरल प्रेजेंटेशंस, और हमारे सारे पार्टिसिपेंट वेट भी कर रहे हैं कि भाई क्या रहा हमारा प्रेजेंटेशन का. इट्स एक्चुअली अ डेलिब्रेट क्यूरियोसिटी इनसाइड in them. So it's time to encourage our delegates who presented their scientific work. And I would like to invite Dr. Sarika Agarwal for felicitation to judges, poster judges, and the presenters.
Thank you, sir. A very good evening to all. As we approach to the conclusion of enriching CME on patient blood management, it is my privilege to stand before you to celebrate the intellectual contributions made through our poster presentations. Before we announce the winners, we take a moment to thank those who made the evaluation process insightful and thorough, our eminent panel of judges. So may I kindly request Shashi Upreti ma'am, Professor Blood Bank, Doon Medical College, Sanjay Upreti sir, in charge, IIMA Blood Bank, Dehradun, and Sushant sir, Assistant Professor, Department of Transfusion Medicine, to join us on the stage for felicitation of our poster judges. Please, sir. So, our first judge was Dr. Nitish Gupta, Assistant Professor in charge, Subhati Medical College, Dehradun. Dr. Vibha ma'am, Associate Professor, Graphic Era Institute of Medical Sciences, Dehradun. Ma'am, please come. Dr. Yatendra Mohan, Assistant Professor, UPUMS Medical College, Sepai. Dr. Garima Dhamnani, Assistant Professor, MGIMS, Jaipur. Dr. Pradeep Banerjee, Assistant Professor, Homi Bhabha Cancer Hospital and Research Center, Muzaffarpur, Bihar. Dr. Anju Kuru, Lecturer, Transfusion Medicine, Malabar Cancer Center, Thalassery, Kerala.
And our dear Dr. Sarika, Assistant Professor, GMC, Haridwar.
Judges, please stay back as we will be felicitating our participants also. So now the moment we have been waiting for the results of poster presentation. We had wonderful variety of entries, each showcasing unique perspectives and approaches to PBM and different aspects of transfusion and patient care. So all posters were good, but after careful evaluation, our judges have selected few posters. So the excellent posters were from Dr. Joysha Deb, Senior Resident, AIIMS Guwahati. Please come on stage. Dr. Dipali Chauhan, Junior Resident, AIIMS Rishikesh, Department of Transfusion Medicine. Dr. Ashwin K. Mohan, Senior Resident, Department of Transfusion Medicine, AIIMS Bibinagar. And Dr. Nikhil, Senior Resident, Department of Hemato-Oncology, AIIMS Rishikesh. So, and this time our organizing team has taken a thoughtful initiative in recognition of the time, effort and academic spirit shown by every poster presenter. So, we are proud to announce that all participants will receive the appreciation certificates and mementos. And this reflects the generous move of the CME for encouraging learning, collaboration and inclusivity. So now I will be calling upon the name of all the presenters. Please come one by one. So now I call upon the name of all the poster presenters. Dr. Pradeep Bhatia, please come. Dr. Sehrish, Dr. Siddharth, Dr. Diksha Kumari, Dr. Chachi, Dr. Chachi, she is not there. Dr. Manaswani, Dr. Amit Chatterjee, Ma'am, Dr. Ram Gopal. Manaswani. Dr. Soumya. Mr. Manoj Kandwa. Dr. Sarath. Mr. Manoj. Dr. Sarath, Dr. Sukrit, Dr. Vandana, Dr. Jomina.
अमित सर आ जाइए प्रेज स्टेज पे एक फोटो के लिए.
Please give a big round of applause. Dr. Bibant, Dr. Prisla, Dr. Kavya, Dr. Surbhi, Dr. Nishtha, Dr. Umesh. Dr. Vandana ka sir. डॉक्टर काव्या बच्चों को सिर्फ नाम पूछो रोको उमेश जाओ तुम भी नेक्स्ट नेम बोलो मैम ऑन बिहाफ ऑफ डॉक्टर वंदना शी इज वंदना का था ना वंदना ठीक है ना वंदना का डॉक्टर उमेश डॉक्टर उमेश A big round of applause to all our participants. So before I conclude,
इतने सारे बांटने के लिए
so now we present a token of thanks to Sanjay sir for distributing so many awards to the participants. And Shashi ma'am. So before I conclude, on behalf of all the alumni, I wish to extend our heartfelt gratitude to our respected Geeta ma'am, Daljit ma'am and Ashish sir for making us part of this wonderful event, and thank you for including us, remembering us, and most importantly for making us feel like we never really left. Thank you ma'am, and thank you for continuing to inspire us and keeping our alumni bond alive. We are honored to be part of this department. Thank you so much ma'am. Sir. Thank you.
So a lot of thank you as already told by Dr. Sarika. So a heartfelt thank to all our renowned speakers and chairpersons, all resource faculty or judges whose expertise and engaging presentation helped us for this CME event. This CME has brought together minds from diverse specialty to emphasize the shift from product focus to a patient-centered approach in transfusion medicine. And for organization of this event has been a collaborative endeavor. I extend my heartfelt gratitude to our respected director, ma'am, dean, ma'am, and whose constant support and leadership has guided us throughout for this session, for this organization of this event. A special thank to our guest speakers and resource persons. I would also like to thank all organizing committee members, residents, and support staff who worked tirelessly behind the scene and Your meticulous planning and execution ensured the smooth running of every session. To our delegate and participant, your enthusiastic participation, insightful questions, and academic curiosity were the soul of this event. We hope the sessions have provided you with valuable takeaway that you can translate into your clinical practice. As we bring this CME to a close, let us carry forward the knowledge, the spirit of inquiry, and the commitment to improve patient outcomes that we have fostered here. Let this not be the end, but the beginning of a renewed focus on responsibility, patient-centric transfusion practices. Thank you once again for being part of this journey. Wishing you all the very best in professional endeavors. Thank you. हाँ, मुख्य बात रह गई है कि शाम का वक्त हो गया है और बारिश का वक्त भी था, तो आज बारिश हुई नहीं, पर फिर भी हाँ, तो इस चाय के साथ पकौड़ियाँ आपका इंतज़ार कर रहा है। हमने सरप्राइज खोल दिया, पर आपके लिए इवनिंग टी वेट कर रही है। आप लोग कृपया उसको लेके ही जाएं। और सभी लोग, ऑल पार्टिसिपेंट्स एंड एवरी पर्सन, प्लीज़ फिल द फीडबैक फॉर्म एंड scanners are available and certificate will be delivered at the registration desk from where you have registered in the morning. Okay, thank you. Any delegate or any person want to give any feedback in video? Any foreigner who has non-black hairs can give the feedback. Share the feedback of this event. This will be needed for us. Yes. So ISBT, for the ISBT, actually it will be good that you are giving any video feedback. So what have you learned, what have you achieved, and how will you implement these things? So anybody is welcome.